I am the experiment.
You can write your own story.
Not stop trying and don't give into the fear.
Before we get started, make sure you're connected wherever you listen. Follow us on Spotify, YouTube, X, so you never miss an episode. Okay.
Nice
Welcome.
to see you.
Nice to see you. Thank you so much for coming out today.
Yeah, glad to.
And you are Patrick Lilley. You're the founder and CEO of Liquid Biosciences, Sciences or Science?
Sciences, yeah, thank you.
Sciences. And that company, what does it do?
So we've been around for about 14 years, and we have a quantitative AI platform that we use in healthcare.
Okay.
So the notion is that if you can predict patient outcomes, what you can do is you can potentially diagnose diseases, you can predict treatment response, you can explore the sort of molecular dynamics of drugs and how they're actually working in the body, identify safety and toxicity issues and why the drugs are working, which in turn spawns more potentials for newer treatments. Okay. And you can do simple things like if a drug works for 30% of the patients, you can use data to predict which 30%, apply it in a very precise manner, and then identify why for the other 70% doesn't it work, and let's go develop a drug to hit those factors.
Got it. We're gonna get into the weeds with all of those things.
Sounds great.
But I just want to say the reason that I have you here is because you and I got to spend some time together on the East Coast.
Yeah.
With some incredible people. And I was totally blown away. We had dinner together and you started talking and you were talking about developing these tests for predicting potential SUD, substance use disorder.
Yes.
And you had your partners there. And I just couldn't believe it when you were talking about this. You've used like an evolutionary approach to computer science. I mean, you were just blowing my mind. And I was like, I have to know more about this guy. And then we did a panel together, and that was pretty interesting, and I think that went well. And then we've since talked. It turns out we live in the same neighborhood. Yeah. So I'm again glad you're here, and we jumped right into Liquid Bioscience, but I think it's important to say why you're on here. So I want to explore. First, I want to learn all about what you do, and I'm going to dig into it with you because. I think some of it's pretty complicated, and I think with that brain of yours, I think it could be hard for people to understand. So I'm going to ask you a lot of questions and get into it with you, and then we'll learn together.
Yeah, the good news is when we're innovating in technology, it's actually helpful to go back to the simplicity and think about a problem in that way, because so many people involved in a field, both of us probably, when we're involved in a field, we see all the details and complexity. It's only when you pull yourself out of it and go back to first principles that you can really innovate and change things.
Yeah, that's true. Yeah. That's true. How long have you been doing this?
This particular company for 14 years. My first use of evolutionary computing, which is literally evolving solutions in servers to solve problems, was actually in 2001 in the wireless industry.
Okay.
So we used a very simple genetic algorithm to optimize how we updated a phone over the air, which we were the first to do it back then. And then we used it for messaging security in my second company, and then my third company was this one, where we're literally building predictive models.
Why? So how does a person go, in your life, how did you get into this? Like, why would you?
That's a good question.
Yeah.
Well, so my educational background is a couple years of computer science, and then I switched to economics, which is another complicated mathematical system, right? Sure. And then I did my MBA, and I specialized in some derivative securities and sort of the game theory of strategy. So I had a lot of quantitative background, and I spent my career in big companies working in every single functional area: operations, finance, marketing, strategy, customer service, eventually engineering, and so on. And so I got a really nice broad perspective. And one of the things that happened was, I remember in 1995, I was asked to come out and give a guest talk at MIT. And the internet was a new thing and nobody knew where it was going to go. So we had some really luminary people there, a small group of about 25, 26 people. And, the head of R&D at General Motors, the president of the Washington Post, the guy who invented the ATM, some really interesting people. And I gave this little talk on the internet and where it was going. But on the way there, I remember I was reading an article in Scientific American when we were approaching Logan Airport. And there was a guy who had taken programmable chips, and he had discovered this thing in the literature called genetic algorithms. And he thought, well, I should try that because maybe I could program the chips, not by explicitly thinking of the program and writing it, but by using artificial evolution to program itself to do what I want. And here was the really interesting thing. He had a very simple exercise. He said, I'm going to put a 1,000 hertz signal in. I wanted to give me a 2,000 hertz signal out. And it worked. So that's all great. So he had colleagues around the world that he wanted to duplicate it so that he could publish and say, yes, the work's replicated. Well, it didn't work for any of them, even with his own software. And he couldn't figure out what was going on. And so eventually he called Xilinx, who is the maker of the FPGA programmable chip. And they looked into it and they called him back and they said, by the way, what's going on here is your chip was in a lot number that has a manufacturing flaw. There's a current leak in one of the gates. And it turned out when he looked into the code, the genetic algorithm found the current leak and was exploiting the flaw to solve the problem. And it hit me that, holy smoke, it can know something the expert doesn't and use it, but it's a fully blind process, just like in nature. And I remember thinking on the approach to Logan, I have to use this somehow commercially. And it wasn't until 6 years later I found an opportunity to do it.
Have you always been this guy when you were a kid? Were you like this too?
Like curious?
To even think of...
from what my mother says, yes.
Like always into... Are you into science? Are you into what?
Yeah, I mean, I was into every subject in school. I loved them all, and I used to read a lot of science fiction, particularly the harder science fiction that was backed by real science. And that was a surprising level of education, but also sort of a way of thinking about things critically. And when you see potential futures evolving in the books, then it gives you a sense of curiosity about, well, what could we be doing with technology to make things get to those futures? The good ones, at least, right?
Jeez, man.
Yeah.
That's amazing. So you're reading Scientific American. You're going to meet some of like the top in the world in this.
Yeah, and I was such a junior guy at the time, right? You know,
sure.
I was
but
30 years old.
You're speaking at this thing with all these. I mean, I think that says something. And so, explain to me more. So the chip, there's a manufacturing flaw in the chip, and I think what you're saying is that the computer itself is, for lack of a better word, it's thinking and it's using.
It's just processing inputs and turning them into outputs, right? Just like any computer does. But he wanted something very specific. It didn't do general computing. It just was a signal processor. But he was doing it as a proof of concept to say, well, could I use genetic algorithms to solve other problems?
But how did the flaw in the chip produce the solution he was looking for?
Okay.
Yeah, explain more.
So let's think of evolution in the real world for a moment. So no species, no animal, no bacterium,
keep going.
No elephant, other than maybe human beings, and we can speculate about other beings having some level of intelligence, but evolution itself has no mind, it has no consciousness, and its only goal is to propagate the species, to give an advantage to each species, and not at the individual level. This notion of survival of the fittest applies to the species, not an individual. But what happens is you get randomness in the DNA of organisms, plants, animals, whatever they are. Sometimes that randomness, there may be a version of a gene that, because the environment has changed it a little, that, let's say, that bacteria can reproduce more. And it's not survival of the fittest. It's that, let's say, it has the ability to reproduce 10x what the former version of it has. So it quickly outnumbers the old one in the population. That's really how evolution happens, right? Through mutations and eventually sexual reproduction, crossover in DNA and all of that. But there are chance changes in environment or systematic changes in environment that are exploited by random differences in the variation of our DNA. And if those are good, good by the sense of, okay, Justin can have more kids because he's a half inch taller than Patrick, so his kids will get more apples from the tree. They have 3 kids each, Patrick's have 2. Within a few generations, that little genetic advantage of a half inch in height will mean that you're 90% of the population within, let's say, 10 generations. And it's a very simple, small thing. And the system's more complex than that, but that's the basic notion. And in the same way, if you've got an evolutionary program that's literally got the DNA being the coding for the computer program that goes on the chip, what's happening is there are many versions of that little program that are created by the evolutionary software. Let's say 1,000 or 1,000,000 different versions. Each of them is tried on the chip. And those small random differences where one is exploiting that particular gate that had the flaw and one that isn't, well, that one will start to solve the problem. It will survive. The other ones won't. And it will get used more and more in the population of the algorithms.
So in some strange way, the chip it's sort of like a random mutation of a DNA.
It is. And in our process, we're evolving a particular form of simple algorithm, and we're using 2 different kinds of mutation. We're using sexual reproduction and mating, and we're using migration.
Before, I just want to get
it's
the
a lot.
Scientific American thing. So as you're reading this in your head, is the article written in such a way where it's clear that this thing mimic DNA in even a more real way because of the malfunction, or did you draw that conclusion from reading the article? Was the article like, check this out?
I think at the time I didn't understand like there is a version of sort of digital DNA. I didn't know how a genetic algorithm achieved it in practice. I understood the mechanism, but not the implementation. And so I wouldn't say I knew that a string of bits was the digital DNA, right?
Okay.
But it was very clear to me that the program is blind and it operates on its own, and it's trying a bunch of things and it's guiding itself toward the objective rather than just a bunch of random tries. Because of the fitness pressure, the algorithm survives because it does well. It doesn't survive if it doesn't. So just like in the real world, the bacteria survives if it gets past the medicine we give it, right?
Sure.
And so what was clear to me was this blind program with no intelligence found something the human professor didn't even know about, exploited it, and used it to reach the goal that he set for it.
That's incredible.
And that was enough, right?
Yeah.
Right there to say, man, I have to look into this.
And this is incredible too, because I mean we're in the age of natural language processing models, which are totally different.
Yeah.
And you talked to me about this a little bit before.
Yeah.
But it sounds like so there was evolution. How do you say it? Evolutionary
Computing.
Computing
Yeah.
that was happening before you.
Yeah, 1969, John Holland invented genetic algorithms, and it's largely been ignored.
Interesting. And genetic algorithms are, I don't know how you explain that simply. I mean, you've already talked about evolution, but can you break that down?
Let's think of an algorithm very simply. So think of a bread recipe.
Okay.
It's a set of ingredients and a set of steps over time and attributes like how much heat in the oven and whatever. So you mix things, you let them sit, they rise, you do these various things. Anything where you do a series of steps to get to an outcome is an algorithm. The selection criteria for a clinical trial are an algorithm. The way you decide how to treat the people that come to your facilities is technically an algorithm. Now, there's judgment around it, right? You have both objective and subjective means that you use because that's who you guys are, and it's effective. But they're all algorithms in the sense that there is some knowledge and there's a set of steps to achieve something.
Do you have to have, in order for it to be an algorithm, do you have to have more information with each step that then takes you to the subsequent step,
or you have progress? You don't necessarily need more information because, again, let's think of the bread recipe. I can lay out all the ingredients on the counter, the spoons and the wheat and the yeast and everything else. I can have the oven in the kitchen. Everything is there. So I'm gaining nothing new in terms of information or things. But as it proceeds, stuff is happening, chemical reactions, things rising, bubbles forming. Then we put it in the oven and cooking causes other reactions to happen. So yes, there is something being gained at every step toward the objective of having a nice warm loaf of bread that we smell and taste, right?
Gotcha. So a series of steps in some sort of order produces some set outcome, and those series of steps along the way is an algorithm.
Right.
Okay, so then take that to...
And a football play is an algorithm.
Okay.
Right? All of these are algorithms. So the question is, okay, so what does it really mean to evolve an algorithm? Well, if you think, so your DNA is the instructions for building Justin.
Sure.
And only you, right? Unless you had an identical twin.
Yeah, no.
And
Not that I know of.
Then you're subjected to the real world, and there's a certain, how many kids do you have? How do you thrive in the world or not, et cetera? And how much do you reproduce? And you thereby contribute your DNA to the species in proportion to, how well your DNA encoded you for the environment in which you live.
Got it.
Okay, just like bacteria evading drugs or being killed by drugs, there's an environment in which every organism lives. In the same way, if you have a computer algorithm, which is, let's say, a simple series of math steps, saying, oh, well, let's take height and weight and some other things and try to predict, is this person going to get type 2 diabetes? That simple set of math steps is an algorithm. Now, there are many things known about every patient. There are many different kinds of math. There are many different ways to combine those. So if we create millions of algorithms out of different kinds of math and different things we know about the patients, some of those are going to be predictive, some are not going to be very good at it. Just like the population of any organism in the world, they're going to be good for the current environment or not. And the consequence of inside the computer, if an algorithm is better than others, those die and it survives and it reproduces. Literally reproduces. I'm not making a metaphor. I'm saying literally the algorithms are reproducing. They make a clone of themselves which undergoes mutation, or they mate with another algorithm that was also good.
God, that's insane.
It's wild to watch it work.
Yeah, that's so. If so, you basically just turn everything loose. You throw in a bunch of different variables, and then it's trying to get through the steps.
Yeah.
Which is the steps is really like you're mimicking evolution. So it's the trajectory of a species.
Yeah.
Yeah, or in a way, I guess
it is.
And then it's going through steps, and then what works gets the benefit of being able to live, and what doesn't work dies.
Right.
But that's computation.
Correct.
Okay, so but instead of DNA, which is computation anyway.
Yeah, we have a string of bits, which is the digital DNA of the algorithm, and that string of bits says, oh, the first instruction uses addition, and it uses these two variables, height plus weight, right? And then it puts it into a memory location. That's a step in an algorithm. The next one might use cosine. Who knows, right? There's a whole set of different math that could be used. And here's what's interesting is nowhere have I said that the human beings running this system are determining which variables are used, which math is used, which numbers are used. It's emerging on its own. And the real benefit of that is you have no biases, no assumptions, no biases. So it's a wonderful complement to the real experts in the field because it's discovering things, it's looking places they wouldn't consider to look, and then handing them a very focused area to focus their big brains and expertise on. But if you look at the way industry works, particularly in diagnostics and pharma, let's take prostate cancer, perfect example. So we have a prostate cancer we just created. And we're going to build a blood test.
A test for
it. Yeah. And we're going to find therapeutic targets for new treatments for it as well. So one of the interesting things about that is if you go search the last 10 years of literature on Google Scholar for prostate cancer diagnostic biomarker, you're going to get tons and tons of papers, 15,500 papers in the last 10 years, all peer-reviewed, all declaring victory on we found protein or RNA or other biomarkers to diagnose prostate cancer. There are no good tests on the market.
Really?
This is true for every disease. I mean, there's a handful of exceptions, right? Exact Sciences has their Cologuard test, which in its second generation is a pretty good test. The accuracy is better than the first generation, and it's based on a series of biomarkers. That's very rare. Very few diseases have those kinds of multi-biomarker tests that are highly accurate. People don't realize that most diagnostic tests and processes today are highly inaccurate. The point I was making, though, is that the experts in the field who write those papers are wrong. Why are they wrong? They're wrong not because they're not intelligent, not because they lack knowledge, but for a very simple reason. And here's where we'll use a nice, straightforward analogy. The reason is they assume that when a molecule in the body is involved in a disease, that measuring it would help you diagnose the disease. In other words, it would be discriminative between people with or without the disease. Sure. We can separate them into groups. But let's take your car for a moment. So let's say that you're driving a combustion car, a traditional car, and you start getting a banging noise in the engine. And you think, man, I've got to take it to the mechanic. But you know cars, and so you're going to make some comments to the mechanic about where he should look, right? But let's say you don't really know cars, you just think you do.
Like everyone.
And you know that one of the most important things for a car is where the rubber meets the road, literally. The air pressure in the tire. So you tell the mechanic, you know what? Tire pressure is super important. It's involved in the functioning of the car. I want you to use the tire pressure measurements in the 4 tires to diagnose that banging noise. And the mechanic looks at you like, this has nothing whatsoever to do with the engine. Mm-hmm. The assumption that I think a lot of researchers in medicine are making is that, again, if a biomarker, if a molecule is involved in a disease, it can help diagnose. But that's the same assumption, if you notice, that the air pressure in the tire could diagnose the specific problem in the engine. Mm-hmm. I don't think they realize they're making this assumption. So what we're trying to do is say, look, guys, you're unbelievably intelligent and knowledgeable. Let us first look where you won't look because you have biases and predispositions, and you focused your PhD thesis in a very narrow area. We're going to cast a super wide net. We're going to find what's actually involved and discriminative. Then we're going to show it to you, and that will help you focus your wonderful time and attention on the right areas.
You deal with a lot of egos.
We do.
Yeah.
We do.
And I'm sure you're good.
And we have to set them aside too, right?
Well, of course, but I mean the way you said that, even like you're intelligent, and I mean that's a huge issue right now.
Yeah.
Because here we have super computation and AI and all these things that are clearly there's just no human being capable of producing the same. They don't have the same perfect memory, and they don't have the same ability to process information.
Yeah.
Now I'm starting to understand this more.
Yeah. Can I hit the large language models? Because there's a good contrast right now.
Please.
So one of the challenges is that the large language models, ChatGPT and all these that have become so famous in the last year or two, mm-hmm. they are not about math. They are about words and sentences and paragraphs and concepts, okay? Where are they learning about medicine? They're learning from the same publications that I just referenced. Those publications are very good at describing the functions of each molecule in the body. They are not good at saying those molecules are discriminative or can be used to diagnose, right? And so I'm red-green colorblind, right? This is about 1 in 11 Western European men are red-green colorblind. Do you think I sat down and taught my kids their colors? No, that would have been a mistake, right?
Sure, of course.
So you find somebody who doesn't have the color blindness. The point is that those AI tools are using the very literature that isn't correct about what is discriminative, what diagnoses disease. And there's another problem. When you think about prediction, we think about prediction as I'm going to make a prediction like it's going to rain tomorrow. But there's a lot more to it, as you know, in your business. You're trying to predict what's going to work for this person to get them to the state I want them to be in after interacting with us, right? When I was growing up here in Southern California, Vin Scully was the voice of the Dodgers on the radio. And man, I used to sit with my dad by the radio and listen to the games because they wouldn't put them on television when they were home games. And he said, high fly ball to right field. Okay, so we can picture that. Do those words tell the outfielder where to run to catch the ball?
No.
Not at all. The outfielder does have in his brain, because he's played baseball since he was 5 years old, he actually has a mathematical formula in his head embedded in his neurons about the arc of that ball. And he runs to where he knows the ball is going to go. He's actually using a mathematical predictive algorithm in his brain. The words can't do that. The math in his brain can. And so what we're saying is the large language models can't make predictions that are specific.
They're just not doing that.
They're just
literally
can't.
just taking in words and it's almost like an echo chamber, because it's just continually reiterate or distilling down or reorganizing the same thoughts. And you're talking about an entirely different. There's a process,
right?
It's a system for sure, but it's computation. It's not the same thing. Let's just say that.
Yeah, and I can tell you the distinction one point further, if you like.
Yeah, please.
Yeah, so just think of in the past, how did scientists work? So Galileo, for example, one of the things he studied was what is the formula for objects falling, and he also took these spheres and he rolled them down these inclined planes, these wooden wedges of different slopes, and he recorded how long they took and what angle the effect had on that. And he ended up with a mathematical formula from those observations that described the acceleration under gravity depending on the slope of these things. So he took observations of the circumstances, the height of the wedge, the angle of the wedge, and the Earth's gravity itself, and the outcome, which is how long did the ball take to go from the top to the bottom. So those circumstances and outcomes he used, and God knows how he did it without calculators, computer. I mean, the people in the past, it's astonishing to think how brilliant they were, right? So he came up with a formula that says, okay, this is how these behave when they roll. And it's a mathematical formula. Why is that important? And by the way, a formula is an algorithm also. It's important because then you can use that formula anywhere and you can say, oh, if I need a ball to go this fast and this far, what angle do I need and what height do I need? You can derive it from the formula. So you can make predictions, you can test the predictions, you can build new systems because you have a model for the real world physics. Mm-hmm. So our goal in building this software was to say the algorithms that we evolve, they have to be models of the real world. So we have to take in, let's say, 50,000 RNA measurements per person. And we have to say, here's 48 different kinds of math and logic functions that might characterize what's going on, plus a bunch of numbers. But what we're after is to create a mathematical formula or algorithm that predicts the patient outcome. And that model can be used for prediction, for simulation, for diagnosis, and for insight into the mechanism of the disease. That was our goal, is to model the world like the past scientists did, but on problems that no human being could ever deal with because there were too many variables.
What is this? Are you, sorry that I don't know this, but are you a pioneer in this space?
I don't know about a pioneer because John Holland invented it in '69. There was a fellow named John Koza.
Was he using it for these solving?
Very primitive genetic algorithms. There is a real luminary in the field, a guy named John Koza, who was at Stanford. I think he might be retired now. And he built tree-based evolutionary computing, which I used in my second company. What we used in my first company was like John Holland's original algorithms. This one...
What is tree-based? What is that?
Oh, the idea of... Sorry. If you think of an algorithm as a series of steps that work up in a tree, like I have two variables, height and weight,
and then you make a decision.
And I add them in a node that says addition is the node and those are the two inputs, you can imagine a tree of all the variables, right? We do it somewhat differently. We use what's called a Turing algorithm built out of Alan Turing's work before World War II. So, because Turing algorithms are the only algorithmic form that is rigorously proven to be able to mimic any system in nature. No other algorithmic form can do that.
How in the hell did you go from reading that article to, did you already have your brain wrapped around this kind of stuff, or did you have to learn it?
Pieces here and there, and then yes, I had to learn a bunch, and we keep learning all the time, right?
Sure. And then, but did you start bringing in people where you're like, I need to find the guy that's the master of?
Yeah, or you find courses online, or you reach out and you talk to people, and you know.
And so, so I'm a business person too, and so there's an entrepreneurial side to me. So, are you zoomed out and like have a vision of? Wait, we can take this and apply this and it can have a use case and these.
Yeah.
And so then you're like, how do I do this? And now you're studying. And
yeah, Justin, the beautiful secret to this innovation, we have 130 trade secrets and patents around the core technology itself, right? Mm-hmm. Most of them are trade secrets because they're fairly simple things. The beautiful truth of it is that most of them are borrowed from some other domain.
Sure.
And I'll give you a brief example. So one of the things that's important is when we evolve these algorithms on a portion of the patients, it's very possible for them to be so fitted to those patients that they don't work on new patients. Okay. So imagine all the prostate cancer patients we had in the data set in the training group. Let's say a third of the patients we used to train the algorithms and evolve. Let's say all the prostate cancer patients wore blue shirts and that was in the data. And none of the non-cancer patients had blue shirts. Well, the algorithm would pick up on that. Mm-hmm. And it would say blue shirts are a diagnostic for prostate cancer.
Oh, okay.
That's overfitting, right? Mm-hmm. That's exploiting something by chance that shouldn't be there. Well, if you then subject that algorithm to another third of the patients or beyond, it will fail because the chances of blue shirts corresponding to prostate cancer are pretty much zero, right? So when you solve that problem, how do you pick the right algorithm out of an evolved population so that it holds up on new patients? That's the central problem we spent 3 years on at the beginning of the company. How do we make sure these algorithms work on new patients so we don't kill people, right? And believe me, it's the thorniest intellectual problem I've ever tackled. Well, one of the components of it is, you have to look at the errors and how they sort of look mathematically, the errors for each algorithm. Now, what's really interesting about this is that the errors and the way they're distributed mathematically corresponds to something called Brownian motion, which is the way smoke particles or gas particles move in a room. What's really interesting is, why are they called Brownian motion? Well, because in the mid-1800s, there was a botanist named Brown. And he was famous for going every place and doing these nice sort of colored drawings of all the plants and naming them. And the famous example was Clarksia puchella. And I have an original lithograph from, or I don't know if it's a lithograph or drawing from him. I bought it at auction because he took the pollen from it and put it in the microscope. And you notice the pollen was moving, you know, where they put it in between two slides with water and the pollen was vibrating. And he thought the pollen was alive initially. Later, it came out that no, what's going on is the water molecules, because there's heat in them, are jostling the pollen. And under a microscope, you can see that. And that motion became known as Brownian motion because his name is Brown. Well, what's interesting is in 1905, Einstein wrote 4 papers published. One of them, which he won the Nobel Prize for, was about Brownian motion and the equations for particle-based Brownian motion and the transfer of heat in physics. And so his mathematics described the jostling of the particles that Brown observed. Now, here's what's interesting. It turned out that if you sort of march forward to World War II, the British were having a problem, which was the German planes were getting through too much. And they were, I think, expending about 2,500 anti-aircraft shells per plane to bring them down. It was unsustainable. And they did a number of things. They adopted the American proximity fuse, they got radar. But one of the things they did was they had a mathematician who came from elsewhere in Europe, Norbert Wiener. And he made a model of the German plane's physics and said, okay, every quarter second or so, here's the cone of probabilities of where they are. And the gunners need not to try to lead the plane, but put a couple of 2 or 3 or 4 shells into that cone of probability. And he radically reduced the number of shells. Well, his math was Brownian motion based.
Oh my gosh.
Now then you go forward to finance and derivative securities, options, futures, and so forth. And there's a very famous, now known as slightly incomplete model, but it was very groundbreaking at the time, the Black-Scholes option pricing model. And it's an equation that allows you to model a call option or a put option on stocks, the right to buy or sell it at a future time. And that's based on the potential movements of the stock going forward. Well, the movements of stock are Brownian motion. So that equation has elements that look like particle physics and look like Einstein's Brownian motion equations. And you can carry this forward into statistics. So it happened to be that I was exposed to a number of things like this.
Because of your economics.
Right, education. And just reading a bunch and working on derivative securities in graduate school and so on. And talking to my former statistics professor who said, you can use the information in errors to help your model as long as you do certain things. And it struck me that that's one of the things we could do. And so we tested and we found. So this is what I mean by we're borrowing ideas from these great people that came before us and repurposing them to a totally different domain because they turn out to be applicable.
That's insane.
There are people before us, Justin, that the work they did was staggering, and again, it is there to be farmed. It's gorgeous.
It's so mind-blowing, though, just to think of your headspace in starting a company or having a vision to even begin to apply this information. And then were you always obsessed with all of the founding great thought leaders of the Western world?
Yeah, my grandfather used to give me biographies of people and all sorts of people. I mean, Wilt Chamberlain and Einstein and just different people.
Was Brownian motion the first one where you were like, we can use this to apply to this? Or
it's hard to say whether it was the first one, but it was one I was pretty familiar with because of the things I had done academically.
And then also, so you're going to work every day and you already had a company at the time, or was this the beginning of a company?
So we had gotten out of our former company and I had been consulting for a couple of years. I was working for a guy in the overseas remittance space. Okay. Helping him help people send money home to their families, basically.
Gotcha. Okay.
So I was consulting to him on a variety of things for a while, and my co-founder and I ended up thinking, okay, well, it's time for us to do something again, because we had started the prior two companies. And he said, let's use evolution again, but let's build a broader platform. Right.
Wow. That's crazy. And so then what does it look like? So is this like you guys are hanging out in a room with a whiteboard? And I'm serious. Like,
Yeah.
Is it, and you're just like spitballing ideas and using...
on the phone and in person, not so much in office. I mean, our first company, we started at the Starbucks down by the Ritz-Carlton, right? We were there like every day. And then talking until 2 a.m., most nights. And so it was a very similar pattern for us. And, we architected, designed. I would look into, okay, what's the market? Where should we go? How do we get funding? Who are the right people in the network? Right. And it all sort of, builds until there's a moment where you get a check and you start actually doing something.
So you did like a raise and did that. And then it's like, this is what we're going to tackle. And you went.
Yeah. We went a couple years without any pay and, the drill.
Full bootstrap.
Yeah. And then we got some seed round investment from some guys in Indiana, wonderful guys, and one of the local angel groups. And
did they know, were you able to clearly define what the hell it was that you were trying to do? Or
we did tell them.
Did they just listen to you and go, it sounds like
Yeah, I think that the technology it just sounded like magic to people and crazy. But it was more that we had a track record as entrepreneurs building highly scalable software, doing certain things. Like our first company with the over-the-air firmware updates is now in use in probably 2-3 billion cars and phones and other devices, because it formed the basis of the standard for mobile device management that's used today. So there was at least a track record of returning good dollars to shareholders. And I think there were a few people that bet on us.
Yeah, you bet on the horse that's won before, right? But you, at this point in your career, you're like evolutionary computation. Did I say it?
Yep, perfect.
That's your thing. You're like, I am...
It's a good hammer. Let's hit something.
Yeah,
right?
And you're like, there's a ton of ways we can do this, and so you're running with it, and you and your partner are building, creating patents, and you're creating new innovations, and you're applying it first to cell phone technology, not cell phone, but updating cell phone software updates. Then you start to move over to healthcare. Meanwhile, you're pulling in math and science from all over the place.
Yeah, every time you encounter a problem,
you giants, Einstein, and so in each scenario where you did that, are you taking the time to really learn all of the theory? And like, how did you even know where to go look?
Yeah, I don't mean to imply that I've become an expert in all these areas.
Course.
Yeah, I mean, I always joke that I'm a dilettante, right? And we used to have this thing I would put on the whiteboard in front of new employees, particularly the assumption of maximum ignorance, right? Let's just assume we know nothing. And so I would learn enough, and my son asked me this the other day, do you read all these books? Well, no, I read the parts I need, right? Later I might read them, but I read the parts I need to understand that concept enough to be able to repurpose it and see how it maps onto what I'm trying to solve. And I'll do the Wikipedia, wormhole thing and dive into all the concepts until I get some idea. And again, sometimes you get into an idea, you see how people are approaching a problem. You don't borrow so much their idea, but the way they thought about it, apply that way of thinking to what you're doing, and you get to an answer.
How do you feel about intuition?
Oh, I think it's real. You cannot assume that you can deductively logic your way through everything. Intuition's a huge deal, and that's why I like to read widely and talk to people from a variety of professions and interests, because you never know where your idea is going to come from. You have no idea.
Yeah, that's as you were talking, for some reason I just had in my head, I imagine you driving and being like, I got it, and then showing up to the whiteboard and being like, hey, here's how I think we could try to do this. Let's mess with this right now, and then playing with a different idea. So I'm starting to get all of this now. So you're applying evolutionary computation to solving all of these problems, and that carries you forward through lots of different business ventures, and then that leads you to where you are now, which is kind of where we started. We went right in, but this stuff is important to get a sense of kind of how things work. I think what's really interesting about you is that you're clearly super bright, and somehow there's a lot of people in this world who have good brains. I mean, you're an outlier for sure, but translating the ability to think the way that you have into a money-making endeavor Like, do you ever think about like how in the hell did you figure that out?
Yeah, so it's interesting. I'll get to the money making in a moment too, because there was a particular conversation I had with one of my daughters about this. But we all have to eat.
Yeah.
And we all have to amass resources to provide security for our families. And so, just as you can, bring ingenuity to problem solving, you can bring ingenuity to this problem of how do I take that and turn it into income for my family, but also for another reason, which is to amass the resources to do greater good. I had a conversation, my second oldest daughter is 29. And when she was in 6th grade, I remember she asked me, why don't you just give away the technologies that you produce? And I said, well, it's interesting because if I did, what I could do is I could establish a foundation and I could raise money every year, donations, build something, give it away for free, and then next year start the process fresh again and try to raise money in a foundation. On the other hand, if I build a product and I charge people, big companies and others, for the benefits that we produce, I can make a profit. And by the second year, I might be able to, let's say, work on 2 diseases instead of 1. By the third year, it might be 8 diseases instead of 1. And so by the time I have a 10-year track record, I've worked on vastly more through compounding than I could at the beginning.
There's nothing wrong with making money.
Not at all. I'm a libertarian economist by education, right? And I think there's another thing, though, that I know you share. So, it's interesting. There was something several months ago that I think reflected a large reason about why we do this. There was a picture I saw that to me was very, very disturbing, not only for the sort of surface reason, but for a reason I'll tell you. There's a picture of London during World War II. And there was a little girl dressed nicely, 2 or 3 years old, and her legs were under some rubble. And she was up on her arms, and you could see she was trying not to cry, but the pleading look in her eye straight into the camera was, as a father, it really hits you. And the thing about it was, you can think of the horror of what Hitler was doing, you can think of the horrors of war, you can think of all of this. But you know what hung around with me for 2 or 3 weeks, and I before I finally processed it? Why the hell wasn't the photographer helping that girl? Why was he taking a picture instead of helping her? And one of the reasons I do what I do is because I feel that when we have certain skills, there's a lot I don't have, but what I do have, I want to apply it to help people at the biggest scale possible. And I think that's not only a moral imperative, but it's truly evil not to do so.
Yeah.
Right?
Yeah. We share that for sure. I have a weird thing since I was young to where I'm drawn towards like where there's the most amount of pain.
Yeah. And particularly when people are helpless, right? You see, they can't pull themselves out of the situation. So you have an obligation to do what you can.
Yeah, for sure. And that's when people's brains don't work right and therefore their thinking isn't working right. So for me, it's like I have elderly people, children, like anything in the world that I could possibly do to help them, and then people that are impaired that can't think, or they're mentally their faculties aren't there. It's like, how do you expect this person to make a good decision about how not to destroy themselves? And so those are like my areas of focus. And then outside of that realm, I'm a big on personal responsibility. And actually that feeds into the way that our models are for treating addiction. But
well, one of the things that's interesting that we talked about before when we met was one of the biggest problems I see in medicine and healthcare and health and wellness and all of it is, how do we get people to do the right things for themselves? And all of us struggle with this, right? I get up in the morning and I look at the workout equipment in the garage and my mind is already starting to make excuses. Well, I got to look at an email. I need to do this. And you have to do the right thing. That's something that I'm very curious about in your endeavors, how you do that.
Well, I'll tell you, we were talking about this morning, and I had a call with these PR people to do some some campaign to talk about this project we're doing. And I was explaining that if we solve, so someone said there's a lot of stigma around addiction. And I said, well, yeah, of course, because people are making poor choices. And one of the people on the call was looking like, and I go, that's the truth.
Right.
They're bad choices. Like anybody who says they're not bad choices is wrong. But I think you got to go a little bit farther in than that and go, why?
Yeah.
And if the part of their their humanity that's supposed to make the choice is messed up, that's the problem. So you got to think of what are all the things that come together to make a choice to go left or right. And arguably one of the most extreme versions of that is substance use disorder, because people are making a choice to take a drug that they know will kill them.
Yeah.
It's hijacked everything about them. So if you solve that to any degree, you're never going to solve it perfectly. That's why I'm obsessed with it.
Yeah.
But if you can make any dent in that, you can take that information and apply it to everything, eating disorders,
right?
The fact that we live in a time of abundance and that everybody has more than they need, and we all have to understand how we contend with the resources we have, right? It's great. We solved it, right? If our ancestors showed up, they'd be like, Patrick, you did it. Look at everybody. You guys are everyone's fat. Everyone's got everything they need. No one's getting chased. That's a great thing. But now we have new problems.
Yeah.
So how do we manage this relationship with our dopaminergic system? And this is stuff
and your point is exactly relevant to our comment about evolution, right? The environment has changed. We changed it.
Yeah.
Right? Civilization changed it.
Mm-hmm. Yeah, now it's mismatched, which is a whole thing. But I want to keep going on this evolutionary computation, because I think what's interesting is everyone wants to know where the world is going, right? And I think you're in an interesting position right now. When you said about, I saw it in your eyes, you're talking about this girl, and I was thinking about this when I was driving around today, listening to a different podcast that you'd done. I thought, my God, if this guy is doing all the things that he says he's doing, and I know you are, it's just, you just need more time and resources and people, because
that's been the struggle. Absolutely.
Yeah. Because you could find answers to all of these questions.
Yeah. Well, the journey was very funny, because, when we took the first few years to really be sure the technology was working, and we did it on a lot of projects where human lives weren't really involved in the same, way, finance, marketing, optimization, things like that. We then started doing academic collaborations, and we would walk in the door with this magic thing nobody ever heard of. If you look, the number of professionals involved in neural networks and deep learning and the current kinds of AI is millions of professionals worldwide. And the special interest groups maybe have 500 or 600 people in my field total worldwide.
Wow.
It's like a fraction of a percent. Okay, it's just been ignored, even though it is the most powerful computation engine known to mankind, because it is what nature uses to compute millions and millions and billions of organisms.
It's how we got here.
It's how we got here, right? I mean, in fact, I had a conversation with IBM years ago, and they said, our system is based on the human brain. That's why it's superior. I said, well, what produced the human brain? So the point was, as we started to do these, we had to very carefully build academic free work as a track record to then show companies to do analytic service work for Big Pharma, for Mayo, for the FDA. We forecasted COVID for the government, et cetera. And as we built that credibility, then we got to a place where we could at least attract investors, not into our own company, but to spin off or partner with new JVs that would pursue individual disease diagnostics or clusters of diseases. And that sort of joint venture model has been very good. It's uneven. Some companies do well, some don't. Better than, I would say, a standard VC portfolio, but we're investing in the intellectual property there. But as you pointed out, the number one impediment is getting the resources, the right people, the right capital. And if you look, the nature of scientific and medical advancement is in fits and starts, and there's tons of resistance. The guy who won the Nobel Prize, Japanese fellow whose name I forget, for how T cells actually work, he spent a very long period of time fighting against the dogma and outright criticism and public humiliation by existing scientists who said, no, it works this way. The guy who, in the mid-1800s, what was his name? Engelweiss or something like a Swiss obstetrician. So he noticed that when he washed his hands before delivering babies, the mothers wouldn't die as much. And he found this out, and he used it. He washed with like a chlorine solution. And he told all the other obstetricians and surgeons and everybody else. It was 25 years before it became common practice. And he was so aware of the burden of suffering, he died in a mental institution. Right? That's not where I want to go. That's not where you want to go. But my point is, the resistance is tremendous, even when you have the track record. And because we spent that time at the beginning of the company solving the reproducibility problem, we've had no prospective failures at all in any of the projects we've done in terms of the biomarkers working. And that's interesting.
When you say biomarkers working,
they work in a test, they work on new patients.
Because I know what you're talking about, and we said it in the very beginning, but I want to make sure the audience gets it. So we're now talking about, you took the company to practically apply evolutionary computation to healthcare and testing diagnostics, right?
Right. Finding which molecules to measure in the blood that you could combine mathematically to diagnose, do you have the disease or not?
And so if you had
simple blood test,
if you could do whatever you wanted, and you had this as your tool to do it, you could predict most any disease before it happens, well before it happens.
I want to separate prediction from diagnosis.
Diagnose.
We have had
early diagnosis,
and we have had some success in prediction as well.
Okay.
But most people don't do longitudinal studies the right way, so the data's not there. But diagnosis, absolutely.
Got it.
And prediction of treatment response when we have the right data.
And one of the huge advantages is that you can predict. And so when you say success rate, you're not failing, meaning that you're not getting false positives or false negatives.
It's not just accuracy. So I'll give you an example. So last year, one of our clients, Minds Bio out of Germany in the US, they were our client in colorectal cancer. We provided them sort of better math for their biomarkers to improve the accuracy of their test. They then said, okay, do you want to work on pancreatic cancer together? And I said, yes, but we'll also do the biomarker discovery for you. So we'll look at the RNA in blood and pancreatic tissue, find the right biomarkers, and then you develop them into a test. We'll license them to you. So we found the set of biomarkers. We licensed them to Minds. They recently, just a few weeks ago, announced they did an independent validation study, and the accuracy was equal or greater to than what we did when we discovered.
Wow.
So it reproduced. And that's been true of everything we've done because we spent that time at the beginning of the company. So we have that really nice track record. But Justin, the challenge is I walk in the door and I say, Justin, imagine you didn't know me and you didn't know that Vahan invited me out to that conference in DC. I'm just some guy on the street and meet with a software company in Orange County. And I say, well, I can diagnose, I can find the biomarkers to diagnose substance use disorder. You're like, yeah, listen, man, I know the disease. It's not that simple. It won't be, But I actually have the track record, and we've done it, and we did it across 6 substances and found what's in common without respect to the substance itself. I have that track record. But the first time I said it to you, it still could appear as a one-off. You're not looking at the fact that we built the Henry Ford assembly line for automobiles and systematized a reliable process of biomarker discovery and test development.
I still need to learn more about it because you have to teach me more about that because the nature of addiction is so interesting because the real idea is like if say I don't know if we should get into this particular section of things right now, but we could. It's about making a decision. So let's say we have every kind of drug of choice out here, and you're saying, I know the biomarker that's going to predispose somebody to addiction to crystal methamphetamine.
Yep.
The only way that I'm going to become addicted to crystal meth is if I choose to pick it up and put it in my body. So can you predict whether or not I'm going to make a choice to do that?
Yeah. We have a bit of an open question in the biomarkers right now. So you met Stu Gitlow, who's the psychiatrist on staff at Ignite, our partner in substance use testing. So when we look at the biomarkers and the nature of them, some of the biomarkers are related to impulsivity, some are, things you would kind of expect, some are related to inflammation. So some of them appear to be the effects of using a substance, but not the particular substance, just the results generally of being addicted.
Ah, okay.
But others appear to be related to predispositions, which is exactly what you're asking. And because these data sets were not longitudinal, they were just snapshots of people with and without substance use disorder, with one exception I'll get into in meth. It's very difficult to say whether those biomarkers would predict that you have a predisposition. I think they would, and I think Stu thinks they would as well because of the biological nature we discovered after the math gave them to us.
Yeah, there's an intersection between psychology and there's I think you could do it.
Yeah.
I think you could, but it would be, for example, somebody who is more sensitive, right? So there are certain genes related to sensitivity. So we talked about this before, the dandelion versus the orchid. You take that and then you combine a traumatic upbringing. then you could say that this world is painful for this person. So their baseline level of just basic comfort is pain, whether it be psychological or physical. So there's a constant state of discomfort. So then you have that person next to somebody who doesn't have that, and the two of them use some sort of substance for the first time. Mm-hmm. One person goes from their baseline, which is relative comfort to euphoria. The other person goes from total discomfort to feeling normal to euphoria. Yeah. The distance is farther, that person's more likely to want to use that drug again.
Yep.
So you could find the stuff that would relate to that.
And so what's so interesting about is both you and Stephen Lloyd talk about this exact combination of genes and environmental influences and events and trauma, right? So what's interesting about it is both of you have tremendous experience with people undergoing the condition and people who don't. And you mentioned intuition. Well, there's probably not a math formula in your brain that says, oh, Bob is going to do this or Pete is not going to do this. But your intuition, when you meet people, I bet you anything, versus mine, for example, is going to be highly enhanced with respect to predicting whether somebody is likely to become addicted.
Yeah,
right?
For sure. It's to a point of it being haunting.
Yeah, exactly. Yeah. Now, what's interesting is what we have discovered by doing this work, and we've done now 320 projects across more than 60 diseases. So the patterns become clear about the kinds of things we're able to see. And what we were able to see is that data about human behavior, data about the genes, data about RNA and proteins floating around right now in the blood, all of those can contribute to predictions. They all contribute different levels, and some are better at discriminating today. But what's really interesting about it is, given that trauma creates emotional response, has physical effects, trauma and its after effects are going to be reflected in the biology of the patient.
Oh yeah, they're going to have sympathetic nervous system dominance. They're going to have more cortisol in their blood.
Right.
They're going to be chronically stressed, and you can measure all of that.
Right. So it shouldn't be surprising that we can discover biomarkers that not only tell you, do you have substance use disorder or are you likely to develop it? And here's the interesting study. Of the 6 data sets we used to discover the substance use disorder biomarkers, one was a methamphetamine data set. Mm-hmm. And there were 3 classes of patients. People who were never users, people who were former users and diagnosed with MUD, methamphetamine use disorder, and people currently with methamphetamine use disorder. And these people that are former were several years out of it. Now remember that the biomarkers we discovered were across all 6 substances. So we were not finding metabolites in the body of methamphetamine itself. So the biomarkers diagnosed, we said, okay, we're curious. Let's do the analysis a couple different ways. Let's put the former users with the current and say, as a group, how accurate is the discrimination between them and people who never used? And then, because they're former, let's assume they don't have substance use disorder anymore. Let's put them with the controls who never used. Mm-hmm. Which accuracy is better? Well, it turned out the accuracy was better when you grouped the two MUD and former MUD, which implies that the biology of the patients, those two groups of people, was more similar than the former users was to people who never used. Mm-hmm. One conclusion you could surmise from that is, okay, well, that either means that there are long-term effects of substance use disorder on the body that we're detecting and they're just persistent.
It's possible.
Or there was a baseline difference between the biology of those people and people who never used, and we're detecting that. And it might be both.
It probably is both. I think that I think there's genetic factors. For example, the DRD2 and DRD4 that I've talked about. There's a lot of literature around that. If you have less sensitive dopamine, then your basic level of satisfaction is going to be lower. Methamphetamine creates 1,000% increase in dopamine in the brain. That's going to feel a lot better for some people than others. That's so interesting.
So now you see why it's so important to us to say we have a perfectly agnostic mathematical method for discovery, but we desperately need the experts, not only the scientists, but the people who deal with the people with the conditions. Mm-hmm. Because, it's so easy in science, we talk about the ivory tower, to never understand what it's really like. And we've all sat on the couch and told the NFL team what to do next. But that's not like being on the field.
Yeah, I certainly have biases for sure. I can't not.
Well, you have to because you've been practicing successfully, right?
I have my own thoughts, and there is a lot of intuition. I'm just so excited to learn where I'm wrong and where I'm right, and I want to beat up all of these ideas to get to some higher form of truth, which is where Vahan and I have like really bonded over that idea. What I'm so interested in, though, is there's the future of healthcare, as far as I can tell. Everything is moving towards computers and computation, just as a broad term, AI and everything in between, is certainly going to be a part of all the future of healthcare, without a doubt.
Right.
And you've got this way of diagnosing things, and ideally early, right? That's if you're looking at biomarkers, you can see this stuff way before it's detectable in a scan.
Yeah, we just announced autism with Ignite Biomedical, the same folks that we did SUD, and we're detecting autism with biomarkers in kids well under 2 years.
Really?
Yeah.
Do you have a degree of accuracy on that? Is it
It's greater than 90% sensitivity and specificity.
Wow.
And we replicated across 13 data sets, 13 different patient groups.
How early could you pull that from a fetus?
Well, it's interesting because one of the data sets is cord blood.
Okay.
Now, there's the big debate. How much of autism is genetic versus environment? And there's two kinds of environment. There's the motherly environment of the womb, and then there's post-birth. Well, the cord blood presumably reflects genetics of the baby plus the 9 months in the womb. So there is some form of environment. And, RFK is talking about acetaminophen. I don't agree. But the question is how accurately can we diagnose autism from cord blood? Because they had to wait. They took the cord blood, then they waited for the kids to get older, and when they got diagnosed or not after a certain period of time, then they marked the database with yes or no. And our job was to basically predict, are they going to develop autism? What's interesting is the accuracy on all the other data sets is above 90%. On that one, it's around 75. And let's think about this. The best accuracy you can get is 100%, right? Sure. The worst accuracy is not actually 0. It's 50%. It's a random guess.
Yeah, sure.
Okay? So the difference between 50% and where you are all the way up to 100 is how much is genetics in the mother's womb. So it looks like about half of autism is a combination of genes and the mother environment. Now, that could be all genes or all motherly environment. We know there are some genes involved, so it's not all mothers. But fully half of autism is outside the womb. It's environmental. So that's a nice exercise.
But Patrick, could you have the certain genes set up to, let's say that every human being is going to get exposed to the same environmental condition, right? And
yes, and some genes will predispose you to that environment, giving you autism, and some won't.
Yeah, so it's like the genes could be there, but perhaps it's because we're not gonna go down the vaccine route, but perhaps one particular vaccine that everybody gets, you combine.
Yeah, let's just say lead paint, right? Because nobody is going to get triggered by lead paint, right? Yeah. So, I was born in '65. In all likelihood, I was exposed to lead paint growing up. Right? It was just used in various dishes and houses and everything else, and somehow I didn't develop autism. That may mean that either I don't have sufficient genetic components to be triggered by the lead, or that there was something else that helped me not get it, right? But there are definitely both, right?
When you find this stuff, do you publish it and make it public, or is it like your trade secrets?
We do publish some papers, but peer-reviewed papers are extremely hard to get published these days when you're using something like evolutionary computing, because the reviewers don't understand it at all. What we've done is we've got a paper out now that explains the technology, and it's for the TNF inhibitors we licensed also to Ignite Biomedical.
Okay.
And that we're using now as a foundation for the credibility for other papers, so we can just refer to it.
Gotcha.
Anything new, it's like I said, the dogma in medicine and science. What's really funny is why should our stuff be considered new when life has been around for 4 billion years on Earth and evolution's been operating?
It shouldn't be, but I don't think people get it. If you'd like to see more of this content, please subscribe to us on our channel on YouTube. You can follow us on Spotify or on X. I mean, I'm the average person can't even natural language processing models. Like, we're at a point now where most people can't wrap their heads around the concepts that are driving
forward. And that's understandable, right?
Yeah.
I can't throw a 105-mile-an-hour pitch, right? So,
but I think it could get there. I think it starts with the potential outcomes. Like if the public sees that if you had free reign, you could do whatever you want. You could develop a test for everything. You could be testing people from an early age for all sorts of different sicknesses and illnesses. And early detection is the key to survival.
Right. And we can do genetic testing, right? We've worked on genetic data sets as well. It doesn't need to be RNA or proteins.
Okay.
It doesn't matter to us. As long as the data are measurements or categories, we can use it.
So the average person sitting here listening to this, if you had the keys to the kingdom, you could produce tests, they could be tested, insurance pays for it, and they would know way ahead of time if they have any kind of the big scary cancers, cardiovascular. I mean, how many different?
Well, we have the ones that we have that are being commercialized by partners right now are in pancreatic cancer, breast cancer, lung cancer. With the Mayo Clinic, we have a joint venture in kidney cancer, not only diagnosis, but staging and recurrence. It doesn't, and we've done Alzheimer's, Parkinson's, ALS. We're about to do frontal temporal dementia, which nobody wants to develop drugs for because when you recruit, you accidentally pull in a lot of patients with other dementias that are biologically different. So the drug doesn't look like it works, right? So I would love to take the diseases and just say, biggest prevalence to least prevalence is in many in parallel as we can, just start going down the data sets and handling them. I would love to do that.
That's amazing. So is that how you've chosen what you've gone after so far?
Yeah. Is it big? Are people suffering, right? The girl again, are they suffering because of this? And are there people who have an economic interest in solving the problem that can partner with us, bring resources, right?
And so then you produce the test that lets people know, but we're only talking about diagnostics right now. There's also the application of this to discover
new treatments.
Yeah.
Yeah.
So we'll move from diagnostics to treatments, but I want to also see if I can explain the evolutionary computation idea in a simple way, and I'm going to oversimplify the hell out of this.
Yeah, good.
But you essentially create an evolutionary system of computation. Computation being a bunch of processing parts of a computer that processes information. And the way that information flows through that computer is that it tries things, and things that work move forward, and things that don't work die off.
Right.
Just like evolution.
So I have one of my daughters works for me. She actually does our literature scientific research. She's 26, and she had like 4 patents by the time she was 19. She's a brilliant person. But what's really interesting is when she was really little and we started this. She said, "Dad, when you describe the technology, it's like little math people." And the idea is each one of the algorithms is like a little guy with some math formulas in his head that predict things. And there's a million of those guys running around, and they're running around to patients predicting things. Do you have cancer or you don't? The more they're right, the more they survive and they reproduce. And so those people are literally dying off if they don't predict well. They're surviving and having their own mathematical kids if they do well. You can really think of it like evolution. That's
a really beautiful picture.
Yeah.
Now I'm picturing the table being covered with a bunch of little geniuses.
It's literally like what happens in nature. It is it's not metaphorical. We have literally produced evolution inside the computer for these little organisms whose sole job is to predict what happens to the patient.
So I'm going to go really out there for a second and say, could you take somebody, if you had enough data about a human being and the way they lived, could each human have their own little version of this that's able to constantly, through the data gathering, provide like alongside of them?
Yeah.
Like so they're growing up.
Think about it this way. So, when you go to Amazon.com, there's a set of things they present to you because of your history and what you've done on other sites and so forth. And we all think of those as being absolutely unique and personalized. At the same time, you might actually fall into a group of 1.2 million men worldwide that have the same interests and habits. I don't know how many it is, but with respect to shopping on Amazon, you might be very, very similar to them. So you have the appearance of it being individualized, even though it isn't. In the same way, what we see is you need to understand our algorithms, when they come out, they're not like these giant neural networks with billions of tokens. The equation to predict response to treatments for inflammatory bowel disease is a simple algebraic equation with 2 variables and like 3 math functions, right, that we license to Ignite. So if somebody's going to take a drug for inflammatory bowel disease, there's 2 inputs, the dosage and a particular RNA measurement in their blood. They're combined in that simple formula, and it says yes or no, this drug's going to work for you. It's very simple. It's not complicated at all. What that means is that underneath all of the complexity and all the individuality, there are common patterns to diseases, and human beings work in similar ways inside our biology. Well, of course we do. We're the same species. If we didn't have that kind of order and lack of chaos, we'd just be puddles of goo on the floor, right?
Sure.
There's real order here. And remember I talked about Galileo? He's looking at observations of the real world and trying to uncover the math formula that describes the real world system of gravity and the spheres and the inclined planes. In the same way, we're trying to uncover the law of physics inside you and every other person with your afflictions.
Wow. It's mind-blowing. And it's the key to personalized medicine and precision medicine.
Yeah, because then we can take each patient and we can say, okay, he's male, he's 40 years old, he's had this history with these drugs, he's got this disease, and he's got these 6 biomarker measurements. Feed those inputs into this model, and it says, okay, infliximab's going to work for him. Entyvio's not going to work for him. This other drug may work for him. And now the physician and the patient have choices where they say, okay, now we know that these are the viable choices and these are the ones we can eliminate, and they can make the decision.
So why isn't this widely supported so that all doctors are using this and insurance companies are demanding it?
Well,
Or
because
is it moving in that direction?
remember what I said about the way the industry approached this was they assumed their domain knowledge would lead them to the right biomarkers for tests. There's more than a 99% failure rate in papers trying to reproduce their findings on biomarkers. Further, this notion of being able to measure multiple RNAs and proteins in a single test reliably and in a low-cost fashion is relatively new. It's over the last, certainly less than a decade. And the regulatory and payer processes are not used to biomarker tests with multiple molecules in them. So there's not that many that have been approved. Exact Sciences was a pioneer leading the way in this particular area in colorectal cancer. So, the world is just not used to the complexity of the test, even though it's actually not as complex as they think. The minute somebody hears math or algorithms, their eyes glaze over and you can see the fear in them, right? But everything is an algorithm. Even the simple choice of, oh, Justin, your LDL is over 140, we need to give you a statin. That's an algorithm leading to a decision. All I'm saying is you might have 6 measurements of different molecules, a little more complicated math, not much, but it's packaged as a blood test that tells the physician yes or no. So I don't think it's going to be that much longer when you see a whole set of tests. We know that we've got several tests coming out in the next couple of years that are very much like this. They're RNA or protein tests.
Wow.
But, things take time in medicine.
Yeah.
And by the way, the insurance companies and the government are extraordinarily slow. I think the FDA is very slow because they're worried about having to be careful.
Yeah.
The payers are slow because insurance companies don't have a lot of incentive to be fast. Right?
Well, I think the insurance companies could be highly incentivized here.
Well, like you said, if you can detect early, what treatment decisions would you make that lower a lot of downstream costs? And then what to them is an ancillary benefit and to you and me as a primary benefit is the reduction of the suffering in the meantime.
Yeah, they early detection could cut so much healthcare spend.
You know what's interesting, though? When we first started doing work in Alzheimer's years ago, because we've done 40 projects in Alzheimer's, is that when we started the work in Alzheimer's, the prevalent view among consumers was, if I have Alzheimer's, I don't want to know. And the reason they didn't want to know was there were no treatments. But here's the thing. If there are treatments under development and you haven't been diagnosed, you can't get into the clinical trial. If you don't know, you can't do proper estate planning. You can't warn your family. You can't do any kind of advanced planning. It's amazing to me that people think this way, that they don't want to know information, because I'd rather know, have the burden of the knowledge and figure out, okay, what do I do about the problem?
Yeah. Have you tested yourself for everything?
Not yet.
It's a personal question.
Yeah,
I guess.
as you can imagine, I take all the normal blood panels and stuff every 6 months, and I monitor and. Yeah.
Yeah, you said you were doing carnivore. You still doing that?
I'm very close to carnivore. I'm one of those lean mass hyper responders, so my LDL spikes.
Okay.
And I'm very comfortable with it being 130, 140. As you've seen the recent studies, that's great. But it went to close to 200. And that's still okay from a mortality curve perspective, but I wanted to drop it down. And so I have maybe another 20, 30 grams of vegetables or something a day to bring it back down to 130. But other than that, yeah, I've been paleo since 2015. Carnivore for over a year with this recent addition back.
You would fit in our community over here.
Yeah.
Everybody's on some kind
By
of
the way, a guy
diet.
you should chat with sometime is right here, Michael Rose. He was the distinguished professor of evolutionary biology at UC Irvine. And he's got, I won't call it a longevity company, but it's a longevity company that he's starting. And he has a podcast. He'd probably want to talk to you as well.
We should do each other's. That'd be great.
But he's a brilliant speaker and a brilliant guy. And he was, whenever you see people talk about dietary things, it's always, it's leptins and it's this, or lectins, or, Gundry. And there's always a good logical story, but then you ask for the evidence, not there. And sometimes people have some evidence, but they don't have a theory about why. And so you're wondering, every time I argued with Michael when he said something, right? Because I'm prone, and I don't mean argue, I mean ask questions. Yeah. He had both the evidence and the theory. And I would say, well, wait a minute, why can't I eat beans anymore on paleo? And he talked about the evolutionary adaptations out of Africa and all this, and he'd say they're pro-inflammatory. But where's your evidence? And he'd walk me over to a poster in his lab. And one of my students did this 3 years ago. And
that's awesome.
And we analyzed his data on longevity with his fruit fly experiments, which are astonishing. Cleanest and strongest signal I've ever seen in biology.
What's he doing?
So he's now retired from UCI very recently, and he's creating a company basically related to health span.
How does he make fruit flies live longer?
So this is very interesting. So the way we met was by chance, but we're using computers to do artificial evolution. He's evolving large 1,000 fruit fly populations replicated 30 to 40 times with selective pressure, where, for example, he says, I've got 1,000 fruit flies in a container. I'm feeding them, they're living. I only harvest the eggs from the longest lived fruit flies. And they're the only ones that reproduce. And he started doing this in the 70s. And after some number of generations, I forget what it was, 50 or 70 generations, you see big effects in the average lifespan of the fruit flies. He got them to live 5x their lifespan. 5x.
And so now he has strong signals around.
Right, that's like us living 500 years.
Yeah.
That's astonishing.
That's crazy.
And when we analyze the RNA and the DNA from his fruit flies and the large replicated populations, unbelievable signal.
So they're genetically predisposed to live longer.
Correct.
And through that, you're now able to look at the difference between the ones that are living normally compared to 5X, and you can see the difference, which points at exactly what's causing it.
Yeah, but here's what's interesting, and this was the shock to me, is I had this naive notion, never having taken a biology class before I started this business, that, there'll be like probably a dozen genes involved in longevity, right? Sounds reasonable. No, it's fully 1/10 of the genome.
Really?
It's a huge proportion, and it's maybe even bigger than that. So for the fruit flies, they have 14,000 genes as opposed to our 20,000. Mm-hmm. We found 1,400 highly, highly significant genes, both through the RNA and direct genetic analysis.
If you were to throw out how strong of a signal, like if they had that genes, they're 100% going to live 5X?
Let's put it this way. We did a discriminated problem, almost like diagnostics. Mm-hmm. We said, okay, let's take the RNA measurements or the genes. We did both. And let's create a classifier, an algorithm that puts the flies into the short-lived group, the 28-day flies versus the 140-day long-lived ones. 100% accurate.
Wow.
And by the way, the discriminative signal, if you looked at the math and the distribution of the scores, they were so far apart, it was like LA and New York. It's like there was no overlap between them.
That's crazy. Is it possible to see what are the biggest drivers?
Yeah, and this is where Michael's research on the paleo diet and a number of other factors is key, but he's also looking to develop therapeutics. And, there's certain things I can't say that I know about how he's going to deliver them. But he is not looking for the typical pharma, one drug, hit one protein target in the body. He's looking to deliver a package to the body that hits multiple systems at once to then lift everything.
That's so interesting. Aging is fascinating because you got degradation of DNA, right? Methylation and all that.
Yeah.
And then, and I mean, you're just losing information. Are you familiar with David Sinclair?
Yeah.
Yeah. And you know how he's said basically that he thinks he can get back to the original blueprint.
Yeah.
Well, his big claim is that he found the original blueprint and that it exists, and we thought it didn't.
And he's a reductionist.
Yeah.
Yeah.
Yeah. Do you think he's correct?
I don't think he's correct.
No.
I think he's one of these guys that has very logical, very scientific sounding things that he says that touch on some realities, but they are a fraction of the total story, and he doesn't really understand the real system underneath.
That's interesting. I think people in your position that work in science and technology, but science, the big issue is that the people that are communicating to the world have to speak that way to get the information out.
But think about the definition of biomarker, right? Because it's such an abstract word, and most people have never even heard of it. The idea of cholesterol as a biomarker, even that's broken down into LDL and HDL and VLDL and so on. It can get complicated fast. But I will tell you, in all of our work, there's not a single disease of any kind other than some extremely rare childhood diseases like Friedreich's ataxia that a single biomarker of any kind, genetic, RNA, or protein, can diagnose the disease. It's always a portfolio of them. And it's very much like when you go into a museum, we can all stand in front of a Van Gogh painting from one perspective and look at it and all perceive because it's flat. But if you go to a sculpture, you have to walk around it to see the full shape of it. The biomarkers are like that. You have to measure multiple things in the blood to get a full picture of the sort of shape of the disease.
Sure.
But what that means is that diseases and the body's response to them are systems, and they're not reductionist. They're not a single target for a single pill.
Gotcha.
All of this was a surprise to me because, again, I had one biology class in high school, and I didn't know anything about biology, and I had to learn it coming in from the side.
Well, I mean, you've done an amazing, hell of a job figuring that out. I think what's interesting about what you've done and what our work is that to try to effectively treat addiction, you have to have something to aim for. The problem with healthcare is not having anything to aim for. Well, not healthcare. It's like cancer. You're aiming for no cancer detection.
Right.
Substance use disorder, chronic disease. It's biopsychosocial is the behavioral health framework. Yeah. So then you go, okay, what does healthy biology look like? What is healthy psychology? What does being socially healthy look like? So you have to establish what these things are. And when I started with biology, that immediately brought me to evolution because I thought, well, there's all this bro science, there's the latest this, the supplement here, the getting super big and jacked and the different things. But the truth is that the best information we have is how natural selection got us
right
to where we are.
Yeah.
And I mean, if you look at the early writings from when I was trying to create the treehouse model, everything was how are we built to live? And then that was where the environmental stuff came into play, where it was like environment changed so much and we didn't.
Yeah.
I mean, if we were studying us in a lab and you change the environment rapidly, that would be a huge factor to consider. Or if you stop moving, if you said, I'm going to make this rat not move anymore, knowing full well that all the other rats that for all the history of rats have run around for many hours a day, hunter-gatherer style, you stopped them moving, that would be a very big thing to look at. Why is the rat not healthy anymore?
Yeah.
Well, obviously.
So Justin, is part of what you're doing trying to bring back elements of the ancient environment?
Absolutely.
That's interesting.
Yeah, absolutely. I think everything we want to know about the health of our species can be answered by looking at the world through an evolutionary lens.
It's so analogous to what Michael Rose was saying about diet, which is under 40 or 45 years old, you can eat your recent ancestral diet. Mine were from Ireland and France. Mm-hmm. But when you're over that age, you need to go back to our deep ancestral diet in Africa. Right? And so his point was he's trying to bring elements of the old ancestral environment to bear upon today's people. That's exactly what you just said.
It makes sense, right?
Yeah, it does.
There's all these weird there's all kinds of different things to look at with this. So, for example, I teach a book in my class. I teach a class here, and I teach a book called Tribe. And the whole theme in the book is that when human beings experience an external threat, an existential threat, that they come together. And it's, contrary to all belief, it's like wartime makes people more happy.
Yeah.
Right? So when we have these threats on the outside, we suddenly come together, and mental health gets better after 9/11. Everyone's united. I think Reagan said that if we want world peace, we just need an alien to show up on the White House lawn, right? And then suddenly the human race. So why is that? Well, it could be that we're all built for love, and you can make it woo-woo, but really there's actually an evolutionary reason for this.
There is.
Which is that when things got hard and there was something bad going on, we had to collaborate more. And anyone who didn't do that died off, and their genes didn't get spread. And so we are built to form interdependent bonds. So if you want to know what socially healthy looks like, you got to know what you contribute, and you got to know what you need, and you have to be able to be clear about how you're contributing to your environment. And people have to collectively align on something. And I think purpose even sits like right square in that. Why humans need purpose so much is because back in the day, it was like, I killed the antelope, you made the baskets, I had to have a purpose. And guess what? If I don't have one, that's a signal. Something's wrong, and I'm going to die because I'm going to be isolated, and everyone else is going to eat, and I'm going to be over in the forest by myself, and that means certain death.
I mean, what you're describing is absolutely the truth here, because people have this funny view of evolution. They keep thinking of individuals and fitness of an individual. But the reality is the mathematics behind cooperation in evolution is the same math that drives large-scale civilizations. It's the same math that drives voluntary transactions in free market capitalism. And there's a very interesting guy. He was the former head of R&D at Goldman Sachs, Paul Burchard. He's in LA. Brilliant guy, 180 IQ kind of guy. He's actually got patents on emotional AI and moral AI. And he does all this super interesting work that's mathematically grounded. And he points out that morality, a system of morality and collaboration, and our human emotions as well that are tied to those things, are an evolutionary imperative and mathematically necessary for civilization
100%.
scale.
100%.
Right? But he's rigorous about it in ways you and I couldn't be, right?
Yeah. Well, and you're rigorous about it in ways that I haven't been, and I want to learn from you, Patrick. Like I hope we could work more on things.
We'll find a way.
Yeah, because so I'll give you an idea. Like where I'm thinking about this is that I don't know how familiar you are with the project that Vahan and I are playing with, CareNet. You are.
He gave me some of the
Okay, so it all comes down to the end result of it is. Any chronic disease, you want better remission. Okay, so how do you do that? Well, he thinks a personalized or precision medicine approach to treatment based on data is the key, right? So how do we collect enough data to be able to know that when this person shows up with this set of genetics and epigenetics, that we start here on this treatment baseline, we start treating them, and then across a period of time, we measure again, based on the new information, then we make pivots and changes, and then we have a better outcome. And then what I've been playing with recently, where I realized we had a hole in our proposal, was that I think we need to study what successful remission looks like.
Yeah. You talked about this in DC. What's the definition?
Yeah. So what would be interesting is if we measured thousands of people that have had SUD but have remained in remission, and you look at a set of biomarkers from them, and then you could establish a target, and you could say, here's what we're aiming for. And it may be that they need to be a little bit anxious, or that they need to be lazy, or it might be counterintuitive. It might
who knows?
Break everything, right?
Yeah.
That we know. But then you take that set of biomarkers, and then you bring it back here, you measure people, and you see how far, they're the same substance, and you go, okay, how different are their biomarkers from Joe's biomarkers back here? And then you start to focus your treatment on addressing the things that would affect those biomarkers. And that would be an approach to, good news is if we don't do anything, we already produce about a 20 or probably, that's conservative, % better post-treatment remission rate. So even if we learn what our model is.
Well, and don't forget what I said, that we don't necessarily need biomarkers in the omics sense. We can take your medical records, your demographics, the things you did, all of that information, and use. We've done that before.
And how much is Vahan really familiar with your?
I think he's pretty familiar, and he sees the way our system would work is we would have data from his system. We would develop predictive or diagnostic algorithms or choice algorithms for treatment. And then our algorithms would be embedded in his system. So when somebody came in, the things you collect about them would fire off at the algorithm that said diagnose, choose a treatment, present it to Justin's team, right?
You could create individualized treatment plans that auto-populate in an EMR. It's like, these are the things you should be measuring, and these are the things you should be targeting. And of course, again, my biases, but also through having done it and watched it work, is I think most treatment should be focused on getting us back to a health state that's similar to our ancestors. So we're looking for those key things. And the assumption is that if you do that right, that most of the issues around SUD that result in SUD will either subside or go away, or they'll become harnessed to your advantage as long as they're translated into modern.
That was a very impressive thought I heard from you in DC was, how do we turn this into an advantage? I had never heard that perspective.
Oh, that's how...
It's obvious when you hear it, which is why it's so beautiful, right?
Well, I think because addiction, really the pathways that it works on is what drives us forward. So what I noticed through, and you said earlier, I bet you can see people ahead of time. You can kind of capture. So like, for example, with you, do you mind if I talk about you?
No, not at all.
What I know about you. I think that, and I know this is true. There's a book I just read about it. Higher IQ is actually one of the variables that exists in people that have SUD. That's an odd one, but you would think it, contrary to popular belief, it's like you're so...
We're not smart enough to turn down the drink? Is that what you're saying?
But people who are smarter tend to have SUD more. So that's one of the things that we see. Another thing is an obsessive nature, right? So you thinking about it late at night, and I'm going. People who can't sleep and are ruminating, that obsessive nature is an inability to be satisfied. There's solid reasons in the brain for why that can happen.
Yeah.
It's not just because you're awesome and you just are really determined.
Right.
There's clear different things around how your dopamine is working in your brain, how sensitive or how dense your neurons are that affect the way that we feel about wanting more. Now, the real issue, though, is, and that's just a few, but if you look at the things that predispose people to addiction, and they're working on all the same basic behavioral pathways that result in behaviors that could, if harnessed, be the greatest advantage. Absolutely. Obsession with something is not a bad thing.
Right.
Endless
you could see it being linked to purpose, right?
Yeah. I always say to the guys here, the reason you're here is because you suck at quitting. And I'm like, but that's a good thing. You want to be really good at not quitting. That's how you win in life, right? The difference between people who win and lose oftentimes is the people who quit early, they give up.
Yeah.
Like you're some guy that you were on meth and you were riding your bike down the street at 2 a.m. with one shoe missing just so you get to your dealer, when everyone else, the normal people that aren't like you, they do cocaine once at a party and they're like, that was kind of weird and I'm not going to do it again. Why is it that you're different like that? Why can't you quit? And how do we take your not quit nature and apply it to law school?
Yeah.
These things seem obvious to me.
Only after you hear them, though, you know?
Yeah. I can't wait to get, I'm so excited to get the message out there more. But this is the most I've talked about Treehouse in this podcast.
It's worth talking about, man.
Yeah, well, I like it, but I'm so fascinated with what you're doing. And I think that... with where things are going with computation, and I think if you continue to get out in the public, and I think you will, I feel like I'm lucky to have captured this interview at this point in your life, because I think the next 10 years of your life, I think you're going to become a very important person in this particular field.
Thank you, man.
But I believe that. So I'm excited that we probably had one of the first opportunities to sit down with you. But the question is, how's the public going to understand what you do? And that's really what it comes.
Yeah, the key for us, I mean, for example, when we help Ignite and others raise money for the joint ventures, is to present in very simple terms. There's a group of people who are suffering like this. There's no way to find them and therefore treat them. All we're doing, forget about all the magic of the math and the science and the computation. The fact is, we're going to produce a blood test. You're going to be able to go to a phlebotomist, Quest, LabCorp, whatever, take your blood, and a couple of days later, you have prostate cancer and it's 99% accurate.
Yeah.
That's the story here, because that first leads to the decision. The other thing we do is, once we have the model of the biology, we can find those biomarkers that are symptomatic, like a fever, versus the other side, which is the biomarkers in the same group that might be nearer to the beginning of the core of the problem. Mm-hmm. Those you want to target with treatments. So we licensed some drug targets for opioid addiction to a company called GATC Health, who you may have heard of. They're in Irvine. They produced a drug to treat fentanyl addiction on the basis of the targets we gave them.
Wow.
So they have an amazing AI that can synthesize compounds, which we can't do. And we are really good at finding what are the things in the body that you want to push on, which RNAs, which proteins, to change the disease. The pairing is powerful because it results in a new way to treat. So we use the diagnostic test to identify the patients. Now there's a treatment for those identified patients. Mm-hmm. Then if you collect the data, we can say, okay, if you collect data on the different treatments, and by the way, you guys are out there because pharma is looking at one drug, you're looking at various aspects of the person, mm-hmm. but you can look at all of those as interventions. If you record those, over time, we can use our system to say, based on the attributes of the person when they come in, which are the treatments that are most likely to work. So now you've got a whole thing from detection all the way through treatment choice, and resolution.
And then disease management ongoing after.
And disease management. Yeah. Like for Mayo, in our renal cancer, we're predicting recurrence, but my goal is to have a blood test that's taken every 2 years after biopsy or after surgery so that you're monitoring the patient. Already they're monitored through imaging, but why wouldn't you retake the recurrence test every 2 years as a blood test to say, are you likely to recur in the next 2 years?
So all these tests, who owns, is it pharma that owns testing? I mean,
pharma is typically not at all involved in diagnosis, and they see themselves as distinct, which is a mistake.
Yeah.
Right, because you can't treat a patient unless you identify them as having the disease, what they call the indication, right? So our job is to make sure that undetectable or inaccurately diagnosed diseases are accurately diagnosed to then get to treatment and then help pharma develop new treatments. We're trying to hit the whole spectrum. So there are a lot of diagnostic companies, and the bigger sort of commodity diagnostic companies like LabCorp and Quest, who were not in the complex molecular tests, their venture groups and some of their strategic players, and we know them, they are actually seeking opportunities to acquire companies, smaller companies that have developed these more complicated, newer types of tests.
That's interesting. I didn't know that. So LabCorp they would license these tests.
Yeah, so the typical way today is that...
I don't know anything about this.
Yeah, LabCorp offers a lot of very standardized...
I thought they were just logistics, but somebody else is doing all the tests.
They do a great job of logistics and sites, and they offer these tests, and they don't necessarily own IP of the tests. Some of these are commodity tests like cholesterol. Mm-hmm. But increasingly, they're saying, well, if we have distribution, if we have patient sites, if we have all of this, and there's higher value tests that might be reimbursed at $1,500 to $2,000 for cancer detection in blood, then why wouldn't we be in that business? Because we can just hook them up to our network. So what they do is, as most big companies do, they say, okay, well, we can either try to develop our own tests, or we can look at the farm of potential venture investments or partnerships with smaller companies developing these and wait till they emerge in an evolutionary fashion to be the winners and losers, and then buy the winners at precisely the inflection point where their test is approved, they've got a reimbursement code, but they lack distribution. Boom, we can get them for a certain amount of money, and it blows up.
Have you been able? Have you personally gotten reimbursement codes have you done that process?
Our JVs and clients have done that, yes.
Have you considered opening like your own lab that just uses tests that you create?
Yeah. So this is a perennial discussion
global
with investors, right? Is they say, well, can you vertically integrate? But you think, as a friend of mine says, let the singer sing, the dancer dance,
sure.
The writer write. And for example, we work with a couple of labs, but our primary lab partner is Cal Biotech down in San Diego, because they have been around for almost 40 years, developed over 200 tests, and they're just good at it, right? For us to learn everything they know about regulatory, reimbursement, lab equipment, processes, sourcing reagents, all of that stuff.
You don't have to. You just create a division, put like a CEO of character in there, and just be like, go do that. And then.
But it's already there.
Yeah.
Right? So, I mean, a restaurant doesn't have cows in the back room, so.
Farm to table.
Baby. Right. Yeah, some of that. My oldest daughter's a chef, actually, has worked in some farm to table places, but that's part of the reason. But even David Barco, who's the CEO of that lab, is now expanding and adding an ongoing CLIA lab to process the tests, not just develop them. So we're just saying, all right, let's build a virtual factory of discovery, validation, out licensing. David does the development. David can potentially do the first few years of the testing in his CLIA lab and then get it to the point where the big guys want to buy it.
Mm-hmm.
And the only missing piece that we haven't systematized is the capital raise. Mm-hmm. Everything else is fully systematized.
Yeah, that's beautiful. I'm wondering what other use cases outside of, I'm still thinking healthcare, but I'm thinking that this concept, the Kennedy thing around we got to go from a sick care system to a healthcare system. There's a lot of talks, and we talked about this earlier, about early detection and prevention, and keeping people healthy so they don't ever get sick, or being able to stay ahead of it, which is wellness in general, right?
Yep.
I know we're going in that direction.
I hope so.
We're working with Blue Cross Blue Shield right now, and they're giving us a bunch of data, and we're going to analyze it, and then we're helping them develop a value-based care model for SUD. It's
beautiful.
Awesome, yeah.
Yeah.
Which is great because we're like linking arms instead of like adversarial. Not that I'm
Is Blue Shield?
Yeah.
Fantastic.
In North Carolina. So shout out to them that they're innovating and doing this. And North Carolina in general is really, really on the forefront. They basically told us they want to be number one in the nation when it comes to the provision of effective SUD care.
Wow.
And they've put their money where their mouth is. I mean, they're pushing to.
That's amazing.
Yeah, it's incredible stuff. So anyways, Blue Cross Blue Shield's doing this. Why I bring that up is that they're, and all the same conversations happening with Aetna, but all these insurance companies are saying, we're tired of paying for 10 treatments that don't work. We want to pay one person to do it right, and then effectively pay the right people to innovate, right?
Yep.
And so that happening, I feel like remote patient monitoring, wellness. For example, like an insurance company saying, okay, I got a pool of 1 million people, more than that usually, but we got 1 million people. If you maintain a certain level of health and wellness, your premiums are lower, as measured by whatever. So you could all be seen by a doctor, you have an annual physical, and this group of people, if they maintain a certain level, a certain BMI, a certain level of fitness, a certain amount of testing, then you're less of a cost burden, and the goal would be to shrink, to increase that pool of people across the line, and then give really good, no out-of-pocket health care to the people who genuinely need it. Right? These are really obvious ideas. So I'm interested in that, but there's a place for what you're talking about, because I think this evolutionary computation model could be used for, if every person sort of had their ability to dump their own information into that on a regular basis. Yeah,
you could develop algorithms to predict many things.
And it could just manage health, right?
I think there's a couple interesting things. One, let's go to the disease side of things and then come back to wellness. So one of the things we tried proposing to insurance companies, particularly the capitated health companies that say they're given $20,000 a year per patient, if the costs exceed that, they eat it. If they're less than that, that's their profit, right? And it's often the case that the bigger companies like United will say, okay, for a set of neighborhoods in New York or whatever, we're going to give you that capitated market and we're going to pay you that $20,000. So they have a lot of incentive to reduce the cost and gain health benefits. There's a bit of a challenge in the downstream cost, because anything they do that's preventive, their patients typically shift networks within 2 years, so the next guy experiences it, and they're missing their collective opportunity to collaborate with each other. But what I proposed to them was very simple. I said, so you have told us in meetings, all of them said the same thing, 5% of our patients are half of our costs, right? Late stage, type 2 diabetes, chronic kidney disease, end of life, there's a set of things. And they said, we understand very well who they are. I said, okay, but a substantial proportion of those people are dying in that year. And they said, most of them. I said, okay, so if they're dying, but you continue to have 5% next year, who are 50% of your costs, somebody's coming in, right? So if that's the case, why don't we take the 95% that aren't in the 5%
figure out who's
and predict who's going to be in your group next year? Now you can do early interventions to prevent them from getting into the next year's 5%. And we can do it without biomarkers. We can do it from lab tests, demographics, past meds, everything you have, because the healthcare system has tremendous medical records and claims data. And we have in the past used that kind of data to predict certain things, like how far out are you going to get knee replacement surgery if you're an osteoarthritis patient? we were able to go 4 years out versus all other AI and statistical methods being 1 year out.
Wow.
Right? Stuff like that, which allows you to get a bigger patient group to attack with an osteoarthritis drug to be preventive. So this didn't fly with these guys because they just couldn't leave the notion of their standard reports in the idea that we know who these patients are.
They're just not that. They're not. I'm always shocked by when I meet with some of those folks. Like, I think they're moving too fast, so they're not thinking. I mean, it's like or there's just these Leviathan machines, and I don't want to speak poorly. I mean, we work with lots of payers, and they do good work with us, and but I've noticed. I mean, when I say moving too fast, they're not though, because it takes like a year to get anything done. It's more like they have 50 projects and none of them matter, and no one's really putting the brain power on any one of them. Part
of the problem is they're big. I've worked in big companies, right? When I was 30, I was head of strategy for Toshiba's, computer division in the U.S., about a $4.5 billion business. That was a relatively small team of 300 people, but in a much bigger corporation, a $50 billion corporation. And what I noticed was we were all, even in our 300-person division, we were highly siloed. And we couldn't talk to the consumer electronics people at Toshiba. We were forbidden from doing so.
Yeah.
It was hard to talk to certain people in Japan, only people directly related to our computer business. And that's not an indictment of Toshiba by any means. Big companies are like this. But what I have noticed is pharma and healthcare in general, people are so siloed that you and I working in cubicles don't know anybody else. You're my neighbor and I go to lunch with you. I have no idea what you do for a living in the company. We certainly don't collaborate. We don't think of bigger strategic initiatives. We might even have the same innovative idea, pitch it to our two different bosses, be working at the same time and never collaborate.
I never want that.
Yeah.
It's interesting because as a person that's bootstrapped a few companies with my family and all that, like, we strive constantly for developing SOPs and systems. You want to make systems.
Right.
But then the fear is that you create systems that just produce absolute people not thinking for themselves.
Yep.
And no creativity. And yeah, that's a constant challenge. But I'm deeply aware of that. And as we grow, and we're going to grow much bigger, I think we're going to be very careful about that.
Well, you have this nice model also of replicated sites, right?
Yeah.
And what's interesting about that is rather than trying to get it, there's obviously, setting aside the logistic problems of bringing every person to a giant site in Kansas, one of the things you can do is you can understand and test different protocols and variations on them in different places, and you will have a naturally emerging sort of species in each place of people that are innovating in a different way, and then you can begin to share that knowledge.
That's exactly right.
And because they're isolated from each other, there is some benefit that their ideas don't. If I have one site and somebody has an idea to solve problem A, the company decides to invest in one potential solution to A. If I have two sites, one pursues one of the solutions, one pursues another one because they independently think of it, and then you get to compare them and see which is best. Right?
You're exactly right. That's exactly how it works. We do the same treatment model in the different sites for the most part. There's a couple of tweaks, but it'll never be the same because you have different people delivering it.
Yeah.
And so what you see is like this person who's been trained in this way or has this background is delivering this information in this way, or this works better for this demographic. But we do have a perfect scenario for sort of doing A/B testing and pulling one thing out and adding something else. But you got to be careful because we're dealing with human beings, and you want to, if you got something
it can't be wild man experiments.
Yeah, you can't be like, oh, we're going to have none of these guys exercise when we know full well that waking up early in the morning and exercising first thing is a key. It's a key factor. Although it'd be super interesting. I would love to see if you just got people in excellent physical condition and had them heavily social, interdependent social relationships and did no clinical, how they'd fare.
Yeah, that is interesting.
I would really, because psychology is so interesting. The question is like, what drives what? And the chicken or the egg, I mean, is it, you got to have neurochemistry right and then people think better? Or do you think better and then behave differently and then that gets neurochemistry right? Like what's the most, that's been asked us so many times, what's the most important dimension?
Yeah. Well, and personality is heavily genetic.
Yeah.
Right,
sure.
Especially introversion and extroversion.
Absolutely, and that's a huge subject of this too. That I think that I think personality. The challenge that we're facing is that I think most people that are looking for answers to the nature of addiction are looking for the way substances metabolize in the body.
Yep.
And I'm more interested in behavioral phenotypes that are driven by genetic switches.
Right, and the body's response. I'll tell you something interesting about cancer that's an analogy to this. So there are companies trying to diagnose cancer, and there's a number of tests out there that try to detect the DNA shedded from tumors. Mm-hmm. Now, it's floating around in your blood if you have a tumor, but it's floating around in extremely tiny amounts. And the way they detect is because it's different from the person's DNA. And they look for particular genetic variants. There's a subset of known genetic variants associated with particular cancers. Well, here's the problem. So if a person has a solid tumor in their body, the thought is, oh, that solid tumor is comprised of all the same cancer cells. It's not. It's multiple species of cancer cells. There are different genetic variants within the tumor. And what's happening is the body's immune system is an environmental influence on the tumor. So are treatments. So what's happening is artificial selection. The species of cancer within the tumor that are killed by the treatments or the immune system go away. The ones that aren't proliferate. And people think the cancer is evolving, but it's really not that. It's that the various species of cancers are going through, artificial selection. What's interesting about that is those can continue to change in extraordinary ways, and some of the medications may induce further mutations. Right? We don't know. Mm-hmm. The number of ways that a cancer can mutate is much larger than the number of ways the body can respond to any cancer.
Yeah, it's so fast.
So you can measure a smaller number of things in the body's response that are more consistent and reliable. So what we focus on is measuring the RNA and proteins in the blood that are associated with the body's response to the cancer. Now the signal is persistent regardless of the evolution of the cancer under treatment.
That makes sense.
And what you said was very similar, right? It's this notion that, okay, I'm doing these particular things to the patient over time. What we need is to find the commonalities in the biology of the patient with respect to their response, their biological response, and their other phenotypic response as reflected in biology to the addiction, to the treatments.
Yeah.
And you're going to have a smaller number of things to examine, which makes the problem easier to solve.
Yes, and to treat it too. You can't have, it has to be winnable. We may discover that there's an exact way to treat addiction, but it's so unbelievably, it's just impossible. There's too many resources needed.
Well,
so you have to find how you capture the most with, you know what I mean? You really.
There's a guy that, I forget his name. He does these little short things on YouTube, and he was like a former CIA guy or something. Mm-hmm. He talks a lot about sort of fooling your mind into doing certain things and how you read people, and he's a very interesting guy.
Is it Andrew Bustamante?
No.
Does he have a big...
No,
okay.
No, I've seen that guy too. So one of the things he says that's so interesting is, so take a sales script, the world's best sales script, and it's working really well for your sales guys. Now give it to an introvert. I'm sorry, but it's not the world's best sales script anymore.
Yeah.
And this is the point.
Mm-hmm. Yeah, you got to tease out what are the base things that, like, I think of it like an operating system. Like, they say 1 in 10 people worldwide, and this is the same in other areas of the world, which is the strongest idea that there's some sort of genetics at play. 1 in 10 people has SUD, and it's been that way for a long time. You can go back decades and see this 10% number, and that's alcoholism, polysubstance, all combined, 10%. So you could argue that 10% maybe they are the extroverts, and so this script works perfectly for them. But the idea is you got to start with, like, what does this particular type of human look like?
Right.
How do they behave? How do they interact? And I have theories about that, and I want to know the answers to them. This is where
the key is to measure, right, and then we can help analyze and predict.
Yeah. So you just start with, like, for this particular group of people, the baseline treatment should include these things because it addresses, like, the key phenotypical behaviors with them. Then you go, let's go one step further and look at how the different, because there's countless different variations of that operating system being biopsychosocial, all the factors that contribute to it, and let's start adjusting treatment along the way to be more effective. And then all that does, that's pointless unless you measure it against what happens after treatment and look at sustained remission. So it's a complicated problem.
Yeah. But here's something interesting. I have complimented you before on the notion that, again, you're looking at many aspects of the patient, not single drug, single target kind of reductionist thinking. One of the corollaries of that, though, is how do you know if people are different from each other if you're looking at them along one dimension? Oh, I'm just looking at people with 2 arms. Well, that's almost everyone. right? But are they male? Are they female? Are they introverted? Are they extroverted? Are they using meth or cocaine? Or what? There's a whole set of things. Are they physically fit or are they not physically fit? If you don't look at all of those, you have no way to know somebody's different, which doesn't lead you to thinking of treating them differently.
That's true.
So if you start with a reductionist premise, you never even think about multiple treatments, which is where we are today in pharma. Yeah.
Well, the scientific method is beautiful, but that's kind of the issue with it, is that you really,
You should hear my 26-year-old daughter complain about the use of the scientific method.
What does she say?
She agrees with you. It's a beautiful method. She says, Dad, look, we've been working in this industry for a while. She says, I've seen like 3 people use it.
Yeah.
They misuse it all the time.
Sure.
They're not, the number of studies we see, one of the first autism data sets we had, which was one of the 13 we used, has only boys in it.
Wow.
And apparently the reason is because, autism is tough to diagnose in girls. Well, okay, so why is that?
I've heard this before somewhere else.
Here's what we found that's so interesting. There's multiple examples of this, but there's an RNA in the blood of boys with autism that's elevated. In girls, it goes down. It goes in opposite directions. So if you just had a test to say, is it elevated? It would say no girls had autism. Or it might say normal girls.
But you have to first tell it that it's a female, and then this is where the...
Right, and there are specific things. All of the forms of quantitative analysis out there, this is going to shock you. If you know 2 things about somebody, 2 variables, 2 RNAs or RNA and gender, there can be a mathematical interaction. Multiply them, divide them, whatever. Most of the equations in neural networks and regression and all the statistics that are used in machine learning and statistics, they don't allow variables to interact. Have you ever heard the term independent variables?
Yeah.
Why are they independent? Because they're treated as mathematically independent and they don't interact.
But that's not how the nature works.
Of course not.
Everything is interdependent.
Right, thinking of income and golf. The amount of golf you consume, there's an interaction with income, I guarantee you, because it's expensive. That's a really simple example.
Yeah. That's crazy.
So that's the frustration, is that we need people to also sit back, like we talked about, and this gets back to wellness. What's the definition of wellness? Let's define it, and then let's find the aspects of which we can measure, and then we can look at efficacy of methods to hit that in the right way.
Yeah, you have to start. You will never hit a target you're not aiming for. People don't, it blows my mind how, and it's because I think highly intellectual people tend to, like more conscientious people really like processes. And so they forget sometimes to even that there's a goal.
Yeah. Let's just turn the handle of the meat grinder.
Yeah, continue.
I'm not looking to see if the meat comes out.
And it's like, but and the challenge with that is, I think the goals that you haven't achieved yet, requires vision to have that, and that's kind of opposite to somebody who's very intellectual, because I mean, you find people with both. You have both, certainly. That's why I asked you, like, how did you come up with the
right?
But you have to have an imagination. You have to be able to see something that isn't there, to even have a goal or a target, or have data that informs you of what the target should be.
You're so spot on for another reason. I have talked about wellness to people in healthcare, insurers, pharma, diagnosticians, a lot of people. If you ask them, what is wellness? They sit and think about it. Inevitably, their answer is not these words, but it means this: absence of disease.
Yeah.
But if I look at any NBA player, their wellness is above mine. Yeah. Right? And I'm disease-free. That doesn't mean...
Right.
So that's a really, really important point. So there's a vision that's required to say, what is that thing? It is not an absence of something.
It's coming. Like the internet, and then the truth being on trial, and all the bullshit that's getting slung around in the world today is terrible. But at the same time, what you have is this meritocracy sort of thing, where people that are discovering things on their own are bringing them to the table, and some of the ideas are bad, but they're popping up, and algorithms are bringing them forward in YouTube, and different things
people
are
trying them. Yep.
So we have this new layer of information moving forward alongside science, which is very slow. And I think a great example is fasting, or carnivore diet, or there's no money in cold exposure or saunas. Right. Doctors aren't, but people are like, this makes me feel better. Then Scandinavia shows this study. Well, this is causing a reduce in all-cause mortality by 50% for 20 minutes a day, 5 days a week. And it's like, we're getting these different things where we're learning, and it's starting to shape the direction that we're going, which is cool. I think, the future is... some days I feel like it's falling apart, but other days I'm pretty excited.
Yeah, well, I'm glad you have optimism. I've always said if you're an entrepreneur, you must be an optimist because otherwise you're just insane.
Yeah.
or stubborn, which we all are.
Yeah, you have to be almost delusional sometimes, especially early.
Yeah, there's some actually quite good evidence that an optimistic mindset, the benefit of that is that when you're optimistic, you will not only consciously but unconsciously work toward hitting those goals and making that positive reality happen. And there's a very funny thing. So I have a strong math background. So as you can imagine, I'm not a gambler, right? I don't gamble.
Sure,
I gamble enough with the business, right? Just being in this business. At the same time, about once every 9 or 12 months, I will buy a single lottery ticket. And not because I expect to win, but because the feeling of the hope for the moment gives a little kick of energy.
Sure.
Right? And just sort of maintains the optimism. And it's not a true reflection of me believing I'm going to win the lottery. It's just the notion of the sliver of possibility gives a little energy.
Yeah.
Right?
I get it. But what you're talking about around belief, I think that's what you mean. Like what somebody believes will help make it come true. Like that there's a lot to that. And I think there could be a quantum physics conversation about that it gets either really woo-woo, like you manifest things into becoming real. But I think what we know, and Google's represented this with their algorithms, is that our pre-existing beliefs, because of the way the brain works, we spend more time ignoring information than... So our brain will orient around what we believe to be true. So if you believe that so for example, I'll use people that come into treatment. If you have a belief system based on doing a bunch of terrible things because you've been sick, no excuse, but that explains it, right? In your belief system is I'm a piece of shit and I'm not worthy. And that's the lens you look at the world through. And your brain's trying to ignore everything outside of your belief system. You will look for evidence to support that that's true.
Yeah.
And so belief plays a role. It'd be interesting to find out if some people are more likely to be able to believe things to be true and make them come true than others.
Yeah, let me come back to that in a moment.
Yeah.
One of the things I want to tell you first is I mentioned to you we've done some work in PTSD, and Ignite has asked us to license PTSD biomarkers, so that's our next project with them. When you think of PTSD, you think of it as a purely psychological thing.
I think most
we already know that we can get better than 95% sensitivity and specificity on PTSD in the biomarkers.
Before or after it's happened?
After it's happened. We have a data set where we're going to try to predict who gets it, because that would be valuable. Do you deploy somebody to this kind of environment or not, right? But we have data sets of first responders, people who were at the World Trade Center who are not first responders, just civilians, and we have some military data sets. And it's quite clear that there is a biological signal from the psychology. So the brain is affecting the biology of the body.
Oh, yeah.
You know this because the business you're in. A lot of people don't believe this. What's really interesting, back to your other point, is one of the things I've wanted to do for a very long time is just sort of a side experiment. We have access to all these wonderful data sets from the NIH, tens of thousands of them for different diseases, where they measure tens of thousands of RNAs per patient or proteins or DNA. One of the things I want to do is take a bunch of clinical trial data sets where treatments were tried on people and there was a placebo arm. Because in almost all trials, there are placebo responders.
What does that mean?
I know they're not given the drug, but they get better.
Oh, got it. Okay.
They improve. This is particularly true in autoimmune diseases. There's and Alzheimer's is true also, but I think for a different reason, is that social engagement happens in a trial, doesn't typically happen to patients when they're not in a trial. And social engagement is very important for your brain, as you already know. You've talked about it. But autoimmune disease, we find, is very biologically driven, is very immune driven, but there's a pretty high responder rate, 20 to 30%, in the placebo arms of the trial. What I'd like to do is throw away all the treatment arms, collect all the placebo arms from all the trials, and predict placebo response from the biomarkers at the beginning.
You should do that.
Because you can think, is it, for example, is it the RNA for optimism? Is it for gullibility? Is it for positive thinking. What is it exactly?
You should absolutely do that.
Now imagine you find the drug targets.
Yeah,
Then you say, now I can develop a drug that if I give a small dose to somebody, amplifies the value of every other drug. So you can give a smaller dose of the real drug, have less side effects, but the same efficacy.
You should do it. There was an article I read about the placebo, and it was like, why are we not looking at this? The signal is so strong. It's there constantly, and it's too strong for it to be not of importance. And then I think somewhere in the article, this was like 5 or 6 years ago, but somewhere in the article they had said that they found some sort of genetic factor that contributed to the placebo response. Have you heard about this?
I haven't. I'll look. Yeah.
I'll see if I can find it. I think it was like a big publication, like New York Times or something.
Yeah. Imagine an amplifier for every treatment.
Well, I think there could be something. So when you said PTSD, you were talking about PTSD and then psychology and then the physical. I mean, there's an intersection between the way we think and feel in the body, and that's the autonomic nervous system. So arousal, sympathetic and parasympathetic, rest and digest, the things that happen when the body's autonomic nervous system shifts from a state of arousal to comfort, rest and digest, is where all of emotional regulation sort of stems from. And then emotions obviously color how we think, right?
Right, and there's floods of stuff.
Yeah, exactly. So if somebody's autonomic nerve, it does not surprise me at all. So for example, if you studied somebody who had PTSD, you might find biomarkers that are related to them being sympathetic nervous system dominant. Their GABA could be lower, so it's not putting the brakes on the sympathetic nervous system, so they're hypervigilant. Mm-hmm. Hypervigilance is going to mean that they're not sleeping well, that they're having racing thoughts, they're going to be laser focused, not notice things, jumpy. You would see all of these things. They would be chronically stressed out, right?
Yep.
Because they're in this constant state. So yeah, that's the thing, is that all these things intersect, but we all want to separate them out.
Yeah,
but they dance together.
Completely integrated, right? That's again why we want to model everything in systems, not independent factors.
Yeah. If you ever have like a thing that you're playing with and you're like, what would be the thing that would affect this? Or what sort of assessment tool that's validated could we play with the data from psychometrics and stuff? You should hit me up, because I have
absolutely. Yeah. It sounds like you have a ton of knowledge there.
I don't have a ton. I just know where to look. Okay. I have a lot of ideas.
That's good enough. So I got a guy who's as good as.
Yeah. Well, no. I have this stuff, but I'm just so curious about it that I think about this all the time, so my brain would run.
Yeah.
Yeah. Well, man, I don't know where we go from. How long have we been going?
A little over 2 hours.
This is great.
Yeah,
it feels like
amazing.
10 minutes. So we should probably close things out, but I think the question I have for you is, where do you think your field is going, and how do you think medicine's going to change and prediction is going to change, and precision medicine is going to change? Like, where do you think that's all headed? Do like your sort of prognosticate the future.
Yeah, your optimism or pessimism will just change the time scale, right? Is it 5 years? Is it 10? Is it 20? But my hope is that we arrive in a place where, for every major condition, whether it's substance use disorder, cancer, neurological diseases, autoimmune, whatever it is, that doctors are assisted by AI and the large language models in saying, okay, the patient has described some things, I'm measuring some things, I have enough information now to send them for a simple blood test or 3 blood tests. I suspect it's one of these 3 things. I think it's MS or chronic fatigue syndrome or whatever. So I'll send them for either the most likely or all 3 of those things, and I'll get a yes or no back, hopefully high accuracy. And then I'll say, okay, of the available treatments, I have some sort of heuristic, or I have another blood test I can give, maybe it was even done at the same time, that says which of the treatments are likely to work for this person.
Wow.
And then they prescribe. And I think what happens is twofold. One, pharma is going to resist this a lot because they already resist pay for performance. TNF inhibitors like Humira, for example, work for, in the long run, after 6 months, for only 30% of the patients. But in the United States, you have to stay on them for a much longer period of time before you're allowed to switch from that first-line treatment to an alternative. In the meantime, you've got a progressive disease, you're suffering, you've got pain, and this insurance system is still paying for this very expensive drug. Predicting it's not going to work for you takes revenue away from the market leader. So they don't want to shrink their market. The up-and-comers that have different mechanisms of action for new drugs, they should adopt a test like this, though, because they should say, well, I can't be first line at all because of the TNF inhibitors. I've got this JAK1 inhibitor, right? So what I'm going to do instead is I'm going to partner with the test to predict, and I'm going to switch all those 70% of people it doesn't work for over to me as first line. So the incumbents, I think, are going to start to turn over the big pharma companies, because it's always the case that the small and medium-sized companies recognize the opportunities to change before the big ones do.
The big ones
I
like
watched
the
this happen
Titanic,
in
trying to steer away from the iceberg, and they don't. They
yeah, look, I watched this happen in the PC industry. I was watching the internet emerge while I was at Toshiba. They didn't recognize it. They were thinking in pure hardware. Where are they today? They're zero. They're gone.
Yeah.
Right? Polaroid is gone. There's plenty of examples of this. So one, I think that notion of pairing the diagnostic with another test for treatment choice is one thing. The other thing is, I think we're going to eventually get the message out, and people will compete with us and start to develop systemic AI models that are mathematical, that will model the biology. And the consequence of that is we will get better treatments that are very specific to particular patients, right?
That's crazy.
I don't think we're going to lose doctors, although in terms of eliminating doctors, I worry about doctors today because they're being paid less and less and told to do more and more paperwork. And we have a physician on our board who's telling me that when you have a practice of multiple doctors who are in their 50s and 60s, when one of them retires, they can't find any young doctors because the young doctors only want to work for big corporations, work 9 to 5, get their pay. They don't want the upside or the headache of managing a practice. But doctors are still necessary. Everything you've said is involving the human touch and the patient experience and how crucial that is. People are very worried about doctors being pushed aside by AI for diagnosis and everything else. But the doctor still needs to be there for time of interaction with the patient because there's so much more to a human being. And if we look at, let's take the advance that we saw in the 80s, which is anti-lock braking in cars. Okay, so the thing is that you think anti-lock braking, man, that's going to replace the human being for deciding when to pump the brakes in a slippery situation. Well, that's true for most of us. But none of the professional race drivers has anti-lock braking in the cars.
That's true.
The very best in the profession will still be the key, and they'll still be there.
Yeah. I think doctors, I think about this all the time. In fact, part of my connection to Vahan was when he started telling me what he was doing. I started meeting with different people in DC in different areas, and all of them were bringing these different ideas to me, and I was like, the way I work is I have this exercise I call the tea leaves, which is I take all the different factors in my life, things that have appeared that seem random, but they're really crazy that they happen to show up, and I lay them out on the table, and I sort of look at them. I use note cards to do it, and I'm like, how does this all fit together? And that helps guide me. That sounds like magic, but it's not. It's just me organizing around what's there in front of me, right? And through that, I came up with this idea that's not, certainly other people have had it as well, that we'll talk about maybe off this, or off the podcast. But basically, I'm pretty sure that AI is going to completely transform, I know it will, transform the healthcare system. And it's going to be because each person is going to have way more agency in making their own health decisions. And so that will affect doctors.
Yeah,
it will. There's no way around it, because with wearables and the ability to feed an AI with all the information that it needs to understand you, and then for that AI to understand everything that was ever published. Again, like you said, though, there's a lot of issues with that, but perhaps you even apply this evolutionary model to it as well. And then you now have this thing that's sort of working beside you as you go through life that's able to pull all the information about you, knows more about you than any doctor ever has or ever will, has super intelligence, not like the version, you know what we say.
Not Johnny Depp.
No, yeah, but it has so much information that it can do computation and answer any question. And then with talking AIs and avatars, you could sit up all night and have a conversation about your sleep, and it could ask you how you're feeling, and that could be logged in, and that could be correlated to how much
more
you move.
assessment. And I think there will be some doctors that resist this, but one of the things we have to remember is it's very easy to complain about physicians in the following way. Endometriosis, which affects probably more than 15% of women worldwide, you know, the tissue of the uterus is growing outside the uterus. Very painful, impairs fertility, all sorts of things. The average time to diagnosis is 10 years. And the only diagnostic method is exploratory surgery. And we're in 2025.
Have you figured this one out yet?
We have the biomarkers for it.
Nice.
Yeah.
Good.
So we want to do that. And every woman in my family has had it, including both the daughters I mentioned. One of the things about it is you can blame the physicians and say, well, they're ignoring the women's pain and saying it's not serious and so forth. And there's some of that. There are a lot of physicians that don't take women's complaints seriously and mark them down as anxious, give them, you know, some sort of benzodiazepines or something. But by and large, the physicians haven't been given proper tools.
Yeah.
This is not a disease that you can easily diagnose from just pure signs and symptoms. You have to do something else. And so our goal was to find the biomarkers in the blood. So once a girl starts missing school because of her periods, you know it's a precursor.
Yeah.
And you get her on a test right away when she's 17 years old. Okay, you've got endometriosis, and now you start to think about what are the interventions to get her off of that before she gets into childbearing years as a, you know.
Yeah, the tools are missing. I told you about being sick, and it was a doctor who developed a stent that, the way that all ended or came out to be was that my main pancreatic biliary duct was closed. And this doctor at Cedars-Sinai that speaks all over the world on this developed a specific type of stent that went in there and
just for
opened it
this.
Up. Yeah, and it ended up, I was better within 48 hours.
That's crazy.
Yeah, my whole life changed.
Such a simple mechanical solution, right?
Very mechanical. In fact, it has like a little pigtail on it, and it slowly twists itself when you eat.
That's fantastic.
I'd have 2 of them put in because the first one didn't last long enough. But the point is, doctors save lives.
Right.
My dad's heart was stitched up by, they did open heart surgery, a bypass on his beating heart in Arizona. And I remember looking at the doctor's hands, and I was like, I literally held him because I was like, I can't believe you just.
Yeah, it's remarkable.
How did you do,
Yeah.
And he stitched up his damn heart. He stitched little hoses on, it's like.
You can't even
No, I can't even. It is beautiful. So we need healers. The question is just where are they going to go and how is it going to work? And they got to integrate, and we need a revamp anyway. I think, America has led the world in so much innovation. A lot of people hate the U.S., but a lot of people came here a long time ago, and it was sort of the seekers and the most adventurous folks, and they all bred.
Yep.
You ended up with this big explosion of innovation, and we have carried a lot of amazing things forward into the world. We've, a lot of what's been born in this country has resulted in a lot of bad things too, but ending a lot of poverty and a lot of terrible things. Now we're the sickest country.
Yep.
And I think the next thing is that we have to find a solution for that and then innovate and pioneer for the rest of the world, because typically the rest of the world will follow you.
Well, they're already following us in our bad habits.
Yeah, exactly. Yeah. So we have to flip the script soon so that we can continue. We've done it through a lot of other means, but we need to show the world what it looks like to focus on health and go from being the sickest country in the nation to the healthiest.
Yeah.
Hey guys, it would really help us out a lot if you liked and subscribed. We have a lot more episodes on the way, and if you like what you saw here today, put your notifications on and you'll know when a new one comes out. And we're excited to get them in front of you guys and to hear what you have to say. So please leave your comments down below.